Good evening. The AIOS runs a very practical webinar series with the theme of walk-in patients, which addresses practical clinical problems every month. And this month we have a very interesting theme of metamorphopsia, which is a very common symptom. And there are various reasons for it, of course. And in the next 2 hours, you'll learn all the reasons for metamorphopsia and how to triage such patients and how to diagnose and how to manage as well. This has been put together beautifully by Dr. Divyansh Mishra from Shankaraya Hospital, Bangalore, and he'll take over and introduce the faculty.
Sure. So good evening all, and thank you, Santosh sir, for the opportunity. So to dive down into the very interesting metamorphopsia topic, which involves all the part of the eye, starting from the anterior segment, mid till the posterior segment. So that's why we have all the faculty from various kind of specialities or subspecialties to say so. So to welcome our chairperson, Dr. Harbin Shnal, he's the president of AIOS. He may join in some time. And to our other chairperson, Dr. A.S. Guru Prasad sir, who is a medical director and clinical service head of the Vitreoretina services at M.M. Joshi Eye Hospital, Hubli. And my mentor, Dr. Mahesh Shanmugam, head of the department Vitreoretina, Shankara Eye Hospital, India. Moderators, Dr. Santosh Honavar, who's a General Secretary AIOS and Director Oculoplasty and Ocular Oncology Center for Sight, Banjara Hills, Hyderabad. Myself, I am Dr. Divyansh Mishra, who is consultant at Vitreoretina at Shankara Hospital, Bangalore. And my colleague, Dr. Tirumalesh, who is my moderator, who's consultant ophthalmologist and vitreoretina surgeon at Narayan Nethralaya at Bangalore. And we have our expert panelists from various parts of India, Dr. Manvi D. Sindhal, who's a head of the department vitreoretina services at Arvind Eye Hospital, Pondicherry. And Dr. Atul Ursekar, who's mentor and consultant at Shri H.N. Reliance Foundation Hospital Research Center, Mumbai. And Dr. Ramandeep Singh, who's a professor of ophthalmology at Advanced Eye Center, PGI, Chandigarh. And to introduce our speaker, our first speaker is Dr. J.K. Reddy, who's a director, Shankara Eye Hospital, Coimbatore. And his topic of presentation would be understanding and managing optical metamorphopsia. And our another speaker who would be talking about triage and management of vitreoretina interface-related metamorphopsia. He's Dr. Vinod Kumar Agarwal. He's an additional professor vitreoretina services at Dr. RP Center, AIMS, New Delhi. Another speaker would be Dr. Kalpita Das, who's a consultant ocular oncology and vitreoretina surgeon at Shankar Nethralaya, Kolkata. And her topic would be triage and management of vascular, which is retinal and choroidal related metamorphopsias. Our another speaker would be Dr. Parthupratim Datta Majumdar, who is a cataract surgeon, uvea specialist, and professor of ophthalmology at Shankar Nethralaya, Chennai. He would be talking on triage and management of inflammatory metamorphopsias. Another speaker would be Dr. Vishal Rawal, who's a consultant ophthalmologist, vitreoretina diseases, ocular oncology at LV Prasad Institute, Hyderabad. He would be talking on triage and management of neoplastic and miscellaneous related metamorphopsias. And another speaker would be Dr. Pulkit Gupta, who's a neuro-ophthalmologist at Salisbury NHS Foundation Trust, UK. He would be talking about neurological associations of metamorphopsia and how to triage them and manage those cases. So jumping on to the presentations from our faculty. So Dr. Tirumalesh, would you want to take over?
We would like to ask Dr. J.K. Reddy to first speak on understanding and managing optical metamorphopsia, and then I think we can go ahead with the discussion. Dr. Reddy, please.
Thank you very much for these nice thoughts, and most of things I'm anti-segment surgeon, so I forget about most of the retina. But I see general ophthalmology patients a lot. I don't restrict myself to cornea practice. We see 80% just walk-in patients, any patients, then we'll be referring to other departments. And remaining 20%, every day, that's our OP, that's the way we work in our institute. So this is a very common thing, metamorphopsia, and they are so much disturbed, the patients, because wherever they see something that is totally disturbing their life, especially professionals. So, is there any optical element in metamorphopsia? That's the question now. And first speaker, And it's a very brief presentation, so I can take a lot and a little bit, only little slides. So metamorphopsia, as the definition gives, wavy lines, but they don't. Nobody sees the lines always in their life. They see the real life pictures. So this is where we diagnose when we see it and do tests. Otherwise, nobody sees the answers grid in their life, no routine life. So it's difficult for them to pick it up in early stages. So it can be, as it is shown, so paracentral. The paracentral usually they ignore because the other eye dominates. So the paracentral things they ignore. When it comes central, only they come. So that's how the CSR patients very present very early, whereas uniocular ARMD patient presents very late because CSR in the central field is affected if they come very early for uh, the treatment. So this always metamorphosis, when there is a uh, uh, damage, it will be associated with some amount of scotoma. If there is no damage, very early stages, we are very difficult to pick up those stages. There won't be any scotoma. Otherwise, there is always a septal scotoma in these patients. In real life, they see like this. So the first picture is right. The second picture is very early case when you go out and see something like that. And the third picture is where there is a associated with scotoma. And is there optical element from the cornea, antisurface, post-surface, or lenticonus, posterior lenticonus, anterior, or lens tilts, IOL tilts that can produce a true metamorphopsia in real life? To say is no. There is no possibility of doing metamorphopsia, producing metamorphopsia of this. What a textbook description, what the Amsler grid shows in by optical phenomena. So, what is about my talk then? My talk is over now. But let us see what is distortions. So this can confuse the patient when they are present to us. I see lines bent. So this is the one. The textbooks are given barrel distortion, pin cushion. Pin cushion occurs with high plus and barrel with minus powers. But usually that's not the situation. No patient with minus 20 says, I got a barrel distortion. No patient with plus 10 says in my clinic, I got a pin cushion. I see the bend or something. They say that things are not very clear. That's all they say. They nobody bothers of the peripheral carcinomas. This all the books are given a lot about we read in postgraduate things about pincushion barrel. But even minus 20 patients, they never complained to me. So many ICLs we did. They never complained to me. I got with spectacles a barrel distortion. So what is actually happens in real life situation? Forget about that. The buildings or when go out tall, they look wet. The upper part looks. This is a typical pin cushion. What should happen in a plus power, plus 5, plus 6? But brain automatically get adjusted. There are many levels of readjustment in the brain. 6 to 8 levels in the retina and more than 2 to 3 levels in the cortex. So they readjust it and makes it a normal image. So they don't complain about this in the real life. So this is a pincushion one with a camera. When you take a picture with a pincushion camera effect, but really in minus 20, minus 15, it should be very obvious, but they never complain. This can be corrected very easily by aspheric optics in the spectacles, but this never happens. So then the books are given that's very literature. Keratoconus can produce metamorphopsia. Actually, they are different. Keratoconus doesn't produce metamorphopsia because the focal points are very different in keratoconus. So actually, you have different focal points in the cornea. The same thing maybe with the lenticonus also. Oh, there's nothing different. There are different focal points. So what they produce is the light will be deviated into side. So this focus in the side. So produces a ghosting of images. That's not actually a blurring of image or a ghosting of image, but not metamorphopsia. So this how in the right side chart, this is a simulated chart in keratoconus with the different people sizes. This how they see. They read. They read 6, 6, 6, 5, 6, 6, 9, even 6, 12, 6, 9 very comfortably. But this how they see it. This is not metamorphopsia. There are many ghosts. For example, in this case, I think there are 7 to 8 ghost images, one below the other, one on the left or right, depending upon where is the ghost. So what is the real problem, optical phenomena in metamorphopsia? They complain the lines are bent, the lines of the road is, when they go, and especially this is very problematic in what we saw in the architects or inspectors or builders or designers. or an artist, when they come for spectacle correction, first they had the oblique cylinder in spectacles, and even small 0.75 or 0.1, especially in minor side. And if those spectacles, when they incorporate optic cylinder and there is a decentration, effective centration, they do have the peripheral images bend, and they do complain. This is a very common problem with the artists and the draftsman who draws and who puts the lines. They say everything looks bad for me. And there's a and the progressive ad, when you give progressive ad more than 1.5, 1.25, and when there's a narrow field, and most of the spectacles except very high end, they produce a distortion. So when they look at the monitor, when they look at anything, when they go on the it looks narrower in the bottom and wider in the top. That's the commonest problem they see it. And especially when their progressive glass are associated with cylinders, oblique cylinders. When they do complain, we remove the oblique cylinder, we just give a spherical equivalent, and they will much better. The symptoms is they get headache after wearing for some time. So when you are giving progressive spectacles first time, small cylinders we try to avoid, especially the oblique axis, -20, -30, or 20, 40, 30 degrees like that. We give a spherical equivalent and we remove the cylindrical component in that to get rid of this problem. So that's why there's nothing else. There's most of the retina work. And anything for discussion, it's okay. We can go for it.
That was an excellent talk, Dr. Reddy. I wanted to ask you, so you have this optical background. So the thing is, a machine like iTrace, can measure the letter distortion, right? So in the principle of, using an iTrace to objectively document how much is the level of distortion, can it be extended, to measure objectively the distortion produced in irregular retinal surface, say like something like CSR?
So anything like a lens tilt or PCO, any optical phenomena, both iTrace and the iTrace is very good equipment actually. So it gives a little bit exaggerated than normal. So the main issue, so there are many higher order aberrations comes in the picture. There it goes wave and goes, but we generally take up to 6 levels. They say in optical is important, it's not important. But what we saw is the most important factor is one which really bothers the patient is a coma and trefoil. The quadrifoil, second spherical aberrations, these are all they don't bother much. Even very high order also, they increases the depth, they are not bothered much. The coma is the biggest problem because that produces diplopia. That's uniocular diplopia or ghosting. One image will be bright, the image will be a little bit. Both are sharp. That is the problem with that. Both they will have two sharp images. One is 100%, 80% brightness, another is that, depending upon the one. So that's how the problem is there more in the given. Coma is most of the common of coma is in the cornea. So this is we call it as simple terms asymmetric cornea or early formfus, whatever maybe. That's perisium or anything can produce coma is very common problem. That's how the multifocal IOLs when you implant, if there is a high coma, more than one diopter, they are terribly disturbed, even they say 6, 7, 6. The other one is the trefoil. These two are the main aberrations that deteriorates the quality of vision. Remaining all doesn't matter. That's what I found in my practice.
Thank you, sir. Any comments from our expert panel? Anybody would want to make a comment?
Only thing is, if you want, yes, sir.
Guru, sir.
Yeah. No, I just wanted to say, congratulate Dr. J.K. Reddy for his very nice presentation. Although the topic was, I thought, a very dry topic, but he made it so interesting. And he brought out all the causes for metamorphopsia caused by non-retina reasons. And so the lesson from this talk is that before we embark on expensive tests for metamorphopsia in the retina, thinking that it is a retinal problem, which we don't find many times, I think we should look at the spectacles of the patient and the other things that can cause, like what Dr. Reddy has enumerated. I think that is a lesson from this talk. Thank you, Dr. Reddy.
Thank you, sir.
Yeah, another point, I think Dr. Reddy would like to elaborate something on the tear film, and do they, is it really cause distortion, the tear film, the MGD? I think I've seen patients also disturbed because of that also, actually, when you have the
Yes,
optical gyro.
it's not uncommon now. The tear film instability is became very common, especially in hypertensive patients or patients with chronic allergic phenomena, which is quite common in cities. And they use a lot of antihistamines along with antihypertensive. That's a deadly combination. So, and associated with that, uh, I more believe though, then I'm a old timer like my father was, doctor, my grandfather was. We believe more, I believe more, they taught me more on taking care of patient as a whole. So I believe more on the nutritional part, like B12 supplements and something, than just putting artificial tears in the eye and teaching them frequent blinking, but there's no alternative. So this one, because they lose sensitivity with the B12, it won't come back. Once the B12 there comes a neuropathy and elderly patient diabetics, it won't come back. So I realize that produces a lot of distortion, but that's not metamorphopsia to come with, as you are telling, that visual disability and real life problems.
That's right.
Just one thing, because the whole ethos of the presentation is how to triage and how to manage. So what would be your take home that this would be the cause for the metamorphopsia or the distortion of vision because of cornea versus any other? So what would be your 2 or 3 takeaway points?
So this first we have to listen to the patient. What is exactly he's telling? He says the lines are bent. Okay, that's fine. Which lines are bent? We have to ask a little bit spend time. So they say the peripheral lines are bent. When I look at the table, when I look at the draft board, these ones are going straightly. This is called, we call it as symmetrical bending. So whereas in retinal problem, it is not symmetrical. It is one point, one focus point. Wherever I see, it is bent.
Very true, sir.
The
Very true. Yes.
remaining all is fine, they say. So like that, the art of taking the history, I find, is more important. That's what AI comes in the play in the future. The AI will ask the question, even doctor is busy. Where do you see it? Then you put the question, then AI will pick up. He's
Symmetric
having
versus
no problem.
asymmetric. Very nice pointers, sir. Symmetric versus asymmetric. Very nice, very nice. And center versus periphery. These are the two very important points as you suggested, sir. Very true, sir. Any more pointers? Are very nice pointers, sir.
So when you have a lot of problems, they say what we do is in keratoconus or something, just to rule out, we have a high myopia with a retinal problem and with the keratoconus and some retinal pathology associated with that. When you see, we just put a trial scleral contact lens and ask the patient how you look now. So still they are having that problem, then it's a retinal problem. That's how we decide.
Sure. Thank you very much, sir. It was a very interesting. Obviously, the topic was very dull, but you made it interesting really nicely, and very nice pointers and take homes for the people who are attending and people who would be attending later on also. So very nice pointers, sir. Sure. Thank you again, sir. Yeah,
Thank you very
Tirumala.
much. All right.
So now I would like to invite Dr. Vinod Kumar Agarwal, who is an additional prof at AIMS. He will be talking to us about vitreoretinal interface related metamorphopsia and how to deal with it. Dr. Vinod.
Thank you, Devyansh. Thank you for inviting me to be here, and thank you, Thiru, for inviting me. I'll share my screen. Is my screen visible?
Visible, sir.
And am I audible?
Yes.
Okay. And first of all, I like to congratulate Dr. Reddy, because I always thought if there is metamorphopsia, we go and have a look at retina. But now onwards, I'll pay attention to the anterior segment also. So, and once again, thanks to Divyansh, so giving me a relatively easy topic, because that is the first thing we think of when the patient complains of metamorphopsia, that is the VR interface disorders. So it's a relatively simple causes. I'll be talking about the common ones. Metamorphopsia, just a little introduction. We have already talked about it. It's nothing but distorted visions when the patients complain that the linear objects they see are either curved or discontinuous. Now, typically, there are two types of metamorphopsia, which are either micropsia or macropsia. And very rarely would be it would be there that patient is not able to define whether they are seeing the subjects smaller than they are, or they are seeing the subjects larger than they are. So this is one useful history, and if one has one can elicit from the patient, then we can narrow down to the various differentials we have in a particular case. Now, when we talk about vitreoretinal interface disorders, many of them can lead to, in fact, the common ones, ERM, that is epiretinal membrane, causes metamorphopsia in 25 to 90% of the cases. Similarly, VMT as well as macular hole, they all can present with metamorphopsia with varying rates of reported metamorphopsia in these patients in various studies. But one thing to remember is that many of these patients may not actually report any metamorphopsia, and they may present with different symptoms in terms of blurred vision or central scotoma, or even decreased vision. Now, if I have to sum up all of these in a single word, I would say the single most important cause of VR interface causes of metamorphopsia is anomalous PVD. So since we are talking about anomalous PVD, just a little introduction about anomalous PVD. We know that when there is a simultaneous liquefaction and separation of the posterior vitreous phase from the retina, that is called a normal PVD. If there is any discordance between the separation of the retina and liquefaction of the separation of the vitreous from the retina and liquefaction of the vitreous, that is what is called as anomalous PVD, and it can lead to various problems depending on how the vitreous contracts to the remaining posterior pole. So I'll not go into the various pathophysiologies of anomalous PVD. I'll just concentrate on how the various disorders can lead to metamorphopsia. So let's first have a look at epiretinal membrane. So when you have an epiretinal membrane, usually it is associated with inner retinal thickening. Also, there is tangential disruption or displacement of the retinal layers. Now, these are the two most important factors which lead to metamorphopsia in the setting of a epiretinal membrane. Sometimes when the ERM is advanced, it can lead to microfolds in the outer retina, leading to distortion of the cone mosaic, and that can also contribute to metamorphopsia in advanced stages of epiretinal membrane. In cases of vitreomacular traction syndrome, you can have inner retinal cyst and thickening, which can lead to metamorphopsia. And in cases of macular hole, there is outer displacement of the photoreceptors, which disrupts the normal form phenomenon of linearity, and that is what leads to metamorphopsia. So again, because most of these disorders are very simple to diagnose, especially the epiretinal membrane, as you can see over here, and a macular hole. Even I would say a novice can easily diagnose these disorders, especially if we resort to slit lamp biomicroscopy. We must be aware that if we just do indirect ophthalmoscopy, subtle ERMs and small holes may be very commonly missed even by an experienced observer. So whenever there is a patient with metamorphopsia, it's advisable that you do a meticulous slit lamp biomicroscopy. And other thing is that you can see the macular hole and epiretinal membrane on biomicroscopy, but the effects of epiretinal membrane may not be visible with the help of biomicroscopy alone. So therefore, OCT is necessary for characterization of the epiretinal membrane as well as macular hole, and its associated affections of the retina. It may happen in the form of retinal thickening. It may happen in the form of inner retinal folds. But last, that is vitreomacular traction syndrome, is a diagnosis which is made on OCT only. Okay. So vitreomacular traction syndrome is a diagnosis which is very difficult to make just based on your clinical findings, and one has to resort to OCT to come to a diagnosis of pure vitreomacular traction syndrome. So I'll just be showing you a few examples. This is the epiretinal membrane, which I showed you just the previous picture. Now, when you see such a membrane, a host of things can be seen in the retina, which would be which can be seen with the clinical examination, but are best seen on OCT. So you can see the type of epiretinal membrane and how it is attached to the retina. For example, this is a globally adherent membrane which is there on the surface of the retina with minimal distortion of the foveal contour. This is a kind of membrane which is again attached to the retina, but there are few empty spaces between the retina and the epiretinal membrane. It causes thickening of the retina and the foveal contour is obliterated. On the other hand, if you see in this particular scan, there is epiretinal membrane. The spaces between the epiretinal membrane and retina are even wider, and there is in fact eversion of the foveal layers. So these are the various types of retinal problems you can encounter in these patients. Sometimes these epiretinal membranes can contract centripetally, whereby the foveal contour becomes deep. That leads to a pseudo hole. If there is a centrifugal contraction of the epiretinal membrane, we can have excavated margins of the foveal contour, and that is called as a lamellar macular hole. Sometimes you will see there is associated macular edema in the retinal layers. You can also see the spontaneous separation, which may be complete or as partial as seen here. Separation of the epiretinal membrane along with the posterior vitreous detachment. And very rare is when you have centripetal contraction of the epiretinal membrane, the central part of the epiretinal membrane gives away, and there is herniation of the retinal layers through this epiretinal membrane. So by doing an OCT in a patient with epiretinal membrane, we can see a variety of things in the retina, and they all can contribute how we understand the patient symptom, how we take up the treatment of the patient, and how the outcomes are going to be. When we come to VMTS, vitreomacular traction syndrome, and macular hole, earlier they used to be two different pathologies, but now with this particular study, we know that they are part and spectrum of the same disorder. What starts with vitreomacular adhesion, if unrelieved, can go on to become a vitreomacular traction syndrome, and subsequently it can lead to a full thickness macular hole. So if you see on your slides, these are all patients with vitreomacular adhesion. So when you have a vitreous still attached to the retina, but there is no alteration of the retinal contour, you can diagnose a patient with vitreomacular adhesion. As you can see, in all these patients, there is a vitreomacular adhesion. And if you see here on your right top, there is a patient there is a diabetic macular edema, and there is a foveal attachment of vitreous. But if you see, the foveal contour is not altered or pulled up by the vitreous, and therefore it will come in the category of vitreomacular adhesion and not vitreomacular traction. And as I said, the main pathology is in all these cases anomalous PVD, and sometimes in OCT you can see a picture like this where there are multiple layers of schisis, as you can see over here. If the vitreomacular adhesion remains there and there is anteroposterior traction, it can lead to a VMTS. As you can see here, initially it just pulls on to the inner retina. Subsequently, there is formation of the inner retinal cyst, which we clinically see as yellow spot, which is also known as 1A macular hole. And subsequently, this cyst extends to the outer retina when we call it 1B, stage 1B macular hole. And in this stage, what we see clinically is a yellow ring. Subsequently, this yellow ring enlarges, that is the outer hole enlarges. And again, we are seeing a yellow ring which is enlarging on the clinical examination. This VMTS may be isolated in the form of just the vitreous pulling the retina, or it may be associated with a epiretinal membrane. And sometimes this VMTS may separate on its own, leading to formation of a PVD, and you can see the epiretinal membrane is still there, but the cyst in the inner retina has dissolved. Nowadays, we mostly follow OCT classification of macular holes. So if there is a deroofing of this cyst which was there, which was extending throughout the retina, it can lead to the formation of full thickness macular hole or stage 2 macular hole when the vitreous is still attached to the inner surface of the retina. If it detaches from the inner surface, it is known as stage 3. And when the vitreous detaches from the disc also, it is known as stage 4 full thickness macular hole. So this is briefly the pathophysiology. And when you do the OCT, you can see all these things happening in a particular patient, and it can give you an idea how the vitreomacular traction or vitreomacular adhesion is behaving in a particular patient. And all these patients are potential candidates who present with metamorphopsia. So once you have a patient with metamorphopsia, you find there is something on the macula on clinical biomicroscopy. While ERM and macular hole can be visible very easily, one can easily go on to do a OCT, and we can see what is happening at the level of vitreoretinal interface. So once the patient has come to you, you've diagnosed the patient, subsequent step is to treat the patient. So I'll be talking about few indications in each of these and how to treat. So epiretinal membrane, if the vision is usually less than 6/12, the patient has a disoblique, then one resorts to treatment. The patient has disoblique metamorphopsia, the patient requires exact visual demands. In that particular patient, you can treat the patient even in vision when the vision is more than 6/12. So treatment is usually vitrectomy with epiretinal membrane peeling. One may or may not resort to ILM peeling in such cases. Most of the patients do improve with epiretinal membrane peeling, but remember, most of these patients do not end up having normal contour in the early postoperative period, and retina may remodel up to 12 to 18 months of time to come to a, I'll say, near normal contour. Sometimes it may not come to a normal contour, but the patients usually report improvement in metamorphopsia as well as improvement in the vision. So this is a classification which was recently introduced, and it is said that when you have encroachment of the fovea by the inner retinal layers, that is the time when you should intervene in such cases, because once you are beyond stage, that is, there is continuation of the inner retinal layers across the fovea, usually the ultimate outcome, both in terms of functional as well as anatomical, is not up to the mark, and therefore one should intervene somewhere at this level and do not let it go unguarded. So this is a patient with epiretinal membrane. In fact, he's a doctor. He's a very active patient. He was 6'6", but the patient has a very disabling metamorphopsia. This was the preoperative picture. And this patient, not for vision, but just for metamorphopsia, underwent vision. The vision remained 6/6, but the metamorphopsia improved significantly, and the patient is very active. In fact, last time he went for scuba diving, he told me, "Doctor, I could enjoy my scuba diving just for you." So that is something, this is how, though the patient, the vision is very good, but you can make a significant change in the life of the patient by a simple surgery. Coming to macular hole, again, I believe that almost all full thickness macular holes would need surgery in today's scenario, unless the patient has very good vision and patient is not having any symptoms. I believe in such cases, the patient will not present only. So therefore, whichever patient with full thickness macular hole has symptoms should undergo surgery. But there are some subset of patients where the OCT is very inviting, but I think autofluorescence is one thing we must look for. And if there are significant RP changes in such patients, a surgery may be avoided, as the visual prognosis is poorer in such cases. Again, vitrectomy, ILM peeling, and gas tamponade is the standard of cares. The patients with smaller holes, less than 400, 500 microns, do very good. But patients with relatively 600 microns, we have to resort to various modifications, and the results may not be as good as smaller holes. So this is a patient who has a full thickness macular hole, has vision of 6/18. This patient underwent surgery, and you can see this is the post-operative picture. The patient improved to 6/6 and near normal anatomy of the contour. And nowadays we give a lot of emphasis on how the outer retinal layers look, and you can see there is total continuation of the ellipsoid zone as well as the ELM. Though EZ looks little attenuated here, but patient maintain a good vision. So one thing you have to be wary about in patients with macular hole is that these patients can still report metamorphopsia after the surgery, and this metamorphopsia again may take up to 12 weeks to improve. So that is something these patients need to be improved. Their vision improves, but metamorphopsia may last longer. Coming to VMTS, when you have a broad-based VMTS, usually the vitrectomy is the treatment of choice. But in focal VMTS, we have several treatment options, observation being one. But if the patient has significant metamorphopsia, one has to resort to treatment. Again, ochreplasmin is an option, but not in India because it's not commercially available. Vitrectomy is usually the treatment of choice. This is pneumatic vitreolysis, something new, whereby you inject a gas bubble in the eye and expect that the vitreous would separate due to the mechanical disturbance by the gas bubble. So in fact, we had done a randomized trial comparing these two techniques, that is pneumatic vitreolysis and vitrectomy, but we found in our study that vitrectomy was much better than pneumatic vitreolysis because of the higher rate of full thickness macular hole in patients with pneumatic vitreolysis. These are some of the images from our study. This is a patient on your left with vision of 6/60. So this patient had a very small kind of attachment, had pneumatic vitreolysis. You can see the foveal architecture improved and the patient improved to 6/9.
Vinod sir, can you kind of summarize?
Yeah, just one slide more.
Sure.
Yeah. So on your right is a patient with pneumatic vitreolysis who underwent gas injection, developed a full thickness macular hole, and we did a surgery and hole closed, leading to improvement in vision. And this is a patient with VMTS who underwent vitrectomy. Again, the patient had significant improvement in vision as well as metamorphopsia. So to conclude, metamorphopsia is a common symptom of almost all VR interface disorders. OCT is an indispensable tool for assessment of VR interface, and choice of treatment would usually depend on the best corrected visual acuity and patient symptoms. But most patients do improve after appropriate management in the form of either vitrectomy, observation, or depending on the patient's status. Thank you very much.
Yeah, I think that was a very nice and extensive view of the vitreoretinal interface disorders. Thank you, Vinod sir. Can I ask Dr. Ramandeep sir? Dr. Vinod, during his presentation, although he showed all the classifications so beautifully with all the demonstrable videos, which are the interface disorders, or which kind of macular holes do you decide not to operate? Because he said he would probably operate any patient who presents. So what's your view on which ones do you say we would not really do a surgery?
I think Dr. Vinod rightly pointed out the things there. So which one I will not do the macular hole. This is like classical teaching that I will expect a patient who has a vision better than 6/12. All right, and I will feel that there's a stage 2 hole that PVD might one day happen and patient may recover. So those are the holes where we give 50% chance they may progress to stage 3, or they may go back to stage 1 and go back to 0. So my thing is vision less than 6/12, and I could see definite focal vitreous attachment, which may likely to spontaneously resolute. Those are the two patients I will do that.
Guru sir, any comments?
Yeah, I think I agree with Dr. Ramandeep. Stage 1 holes probably would be watched unless it's a stage 0 hole where the other eye has had a macular hole and this eye, then I would still not operate, but probably watch it more closely, because that is there's a high risk of developing the macular hole and progression to stage 1, 2, 3, 4. So that is one thing. Secondly, very large holes with loss of EZ for a very long, extensive area, extensive length, and RP atrophy, and probably autofluorescence showing the mottling, which he very well showed in the presentation. Those are the cases which should not operate because of the sheer futility of the effort. There won't be any outcome from those cases unless you want to show the patient that you have closed the hole and make him psychologically better off by doing an inverted flap or doing an ILM transplant or a retinal autograft. All these are gimmicks which usually don't work in terms of causing better outcomes in terms of vision. But to show the patient that the hole is closed and make the patient happy, sometimes they feel happy and at least like we say, the retina is attached, but the vision, the patient is happy about it. Similarly, for the macular hole also, these are the few indications where I will operate on very large holes, otherwise usually not.
So I have one more question, and this is regarding the epiretinal membrane. So we quite often get those patients where there is a well-defined membrane, and you see that there is a small cystic kind of a degeneration which is there beneath. Sometimes you also get ERMs, where there is a visible ERM, there is mounting of those layers, but the vision is pretty much still 6/6. And till you ask them, they probably don't know about metamorphopsia, right? So is the OCT diagnosis a point where you start a discussion with the patient that they might require surgery at some point of time, or is it evidence enough to operate? I was thinking of asking to Dr. Mahesh, but then I think Vinod sir went for it. So, sir, what do you think?
It's okay if okay. So my take is usually ERM is a totally different scenario as compared to a macular hole. Epiretinal membrane can remain stable over large periods of time, and especially patients who do not have any symptoms, I usually do not tend to operate unless the vision is less than 6/12.
Yeah, Guru sir, please.
I just want to add a point here. I think it is good to educate the patient about the problem. He may not have symptoms. He may not be complaining of the symptoms, but we have to educate the patient and make him realize that he has this problem. And maybe because of our education or telling him about the condition, he might later on realize that he really has metamorphopsia and he should do something about it. And he can have a better quality of life. I think this is our duty. We may not force the patient to operate. We will probably operate only when he asks for it. But I think education is important.
Dhruv, can I say something?
Yeah, of course, sir. Please go ahead.
Just to taking Dr. Guru Prasad's point a little further, there are ways to quantify the metamorphopsia. We have M charts, we have the preferential hyperacuity parameter. Is there any role for that? If you can quantify that the the metamorphopsia is increasing in numbers, so should we be doing such thing? Is there any experience, Dr. Vinod, or anybody has that experience with the M charts or PHP? You got my point. The vision is stable, but the M charts value is increasing. So should we? Is there any?
I don't have any experience with M charts. In fact, I was trying to procure them, and we could not while I was doing study for metamorphopsia in RD patients, retinal detachment patients.
Because I think this issue of retina has a publication on role of M charts in a macular hole, and they have shown good results in less than 500 micron macular hole, both using inverted flap and conventional technique. They showed that the values at 1 year, the M charts values are equal in both the groups. Actually, I think this is actually something to look forward to. The M charts or the PHP, the preferential hyperacuity parameter. Yeah.
So one last question. I think Divyansh, we still have time, isn't it?
Yeah, sure, sir, sure.
Yeah. So in a ERM patient, I think Dr. Vinod showed in one of his slides where you do have a well-defined membrane. Sometimes there is a herniation of the retinal contents. That's one scenario, and another scenario being there is a dome-shaped kind of a configuration which is already there with ERM, and the vision is somewhere around 6/18 or lesser, and your in herniation probably it is about 6/60. So when you do the surgery, what is it that you tell the patient, or what should be the patient expectation that we should educate the patient? Can I ask this to Dr. Mahesh, please?
Yeah, thanks, Dr. Thiru. So what I tell the patients with ERM is that, like, despite the surgery, some of the metamorphopsia may persist. So not all the patients, the metamorphopsia goes away. So it can largely decrease, but some of them, it may persist. And like that would mean a very unhappy patient if they have metamorphopsia persist after that. So there is no way we are quantifying that like this particular patient metamorphosis will go away completely. So the younger the membrane, possibly it may go away, but then like the older the membrane, it's been there for a longer time, it may persist and it may get better. So that's something which I tell the patient repeatedly. So most of them take it and most of them adjust, but some of them are unable to adjust. That's something which I'm particular in telling the patient. That's another reason why I would probably not operate on an asymptomatic ERM as well. So there's no way we can guarantee that the metamorphopsia which the patient is not noticing, we make them notice and then we do the surgery and then it persists, then it's a very unhappy patient.
So just to close it, Dr. Vinod, do you want to give pointers for how to triage a case of metamorphopsia which is affected by vitreoretinal interface? So 1 or 2 pointers.
I think the most important thing, first thing is I ask the patient, I assess in terms of visual acuity. If visual acuity is less than 612, I have lower threshold for surgery, even if the patient has no metamorphopsia. But if the vision is more than 6/12, then patient symptoms count a lot. Only if the patient is significantly worried by the patient or his daily routine activities are disrupted by metamorphopsia, I would advise for surgery in patients with vision better than 6/12.
So not for surgery, so the triage. So like if a general ophthalmologist is seeing a patient, he's seeing a case of metamorphopsia with an ERM. So what would be your take home for him?
I think refer to a
Retina specialist or get an OCT done. So like investigation or a retina specialist OP.
Yes, epiretinal, whenever you have a problem with the vitreoretinal interface, I think even most of our anterior segment surgeon friends have OCT nowadays. OCT is the first thing being a non-contact investigation. That is must. I thought I emphasize it very clearly. That is the point whenever you can see something on fundoscopy. Even if you don't see anything on fundoscopy, patient has metamorphopsia. You will not go wrong in doing a optical coherence tomography.
Oh, sure. Thank you, sir. Thank you again. Yeah, thank you for the lucid presentation. Yeah, Tirumalesh sir.
So moving on to another interesting topic. So I would invite Dr. Kalpita Das, who will be talking to us on triage and management of vascular-related metamorphopsia. Dr. Kalpita, please.
Good evening, everyone. And thank you, Dr. Santosh sir and Dr. Divyansh for this opportunity. Is my slide visible?
Visible.
Yeah. Okay. My topic for today is that triage and management of vascular-related metamorphopsia that is related to retina and choroid. So metamorphopsia actually is a symptom of vision dysfunction where the straight lines appear wavy and distorted. So there's a whole lot of macular pathology which can give rise to metamorphopsia. Actually, any macular pathology which is relatively acute in onset and of shorter duration can present with metamorphopsia. And even many of cases who present with metamorphopsia might be having a good visual acuity. However, the symptoms can be extremely debilitating to the patient, particularly those who are visually active. So metamorphopsia related to retina can be due to diseases which affects the outer retinal layers, or diseases which affects the inner retinal layers, or disease affecting the vitreoretinal interface. So diseases affecting vitreoretinal interfaces has already been very well covered by Dr. Vinod. So I will be covering the next two entities. So I will try to keep the presentation based on the clinical scenarios. So first I will be I'll be discussing about metamorphopsia with having some obvious macular or choroidal pathology. So the most common disease entity probably in our routine clinical practice remains neovascular AMD. So this is a 67-year-old gentleman who came with a sudden onset metamorphopsia in the left eye for 2 weeks. Visual acuity was 6/9 and 6, but OCT showed subretinal hyperreflective membrane with subretinal fluid. OCT angiography showed a very well demarcated neovascular complex, and this particular gentleman responded well with anti-VEGF injections. His vision recovered to 6/6 and 6, and post-treatment, his symptoms of metamorphopsia resolved. So another disease entity very common which usually affects young individuals is CSR. So when a patient with CSR presence, we need to take the history whether there is steroid intake or stress. Mostly this CSR resolves on its own. However, this is known to have recurrent attacks, and in case it's a long duration, we need to identify the focal leaks, and we need to laser them. And many cases resolves with outer retinal alterations. So particularly this outer retinal alteration, which is responsible for persistence of metamorphopsia in these patients. Some of the CSR case can resolve with some chronic cyst or RP undulations or presence or some residual large PED, which can be the cause of persistent metamorphopsia for a patient with chronic CSR. CSR in its long spectrum can sometimes present with a pachychoroid neovasculopathy, where we can see there's a development of choroidal neovascular membrane with subretinal fluid, and OCTA can demonstrate a well-demarcated neovascular complex, and this group of patients need treatment with injection anti-VEGF. So this is a particular patient who actually was a very known case of IPCV. So he previously received treatment.
Your slides are not there, Dr.
One minute, sir.
You want me to present Dr. Kalpita from here?
Just a minute, if I can.
Sure.
No problem.
So, okay, Dr. Kalpita is ready probably. Okay. So till the time she is getting ready, so queries from this presentation, sir. But Thirumalai sir, do you want to take up little queries?
Yeah, we can discuss.
Okay, so I think Kalpita is ready. Okay.
Yeah.
Sure, sir.
So this patient who was a known case of PCV was previously treated with PDT and Lucentis in 2009 and 2017, was stable for a long duration of time, but then suddenly presents with a sudden onset metamorphopsia with a drop in the central visual acuity. So his visual acuity on presentation was 624, and here we can see there's a presence of subretinal fluid as well as some subretinal hyperreflective membrane. And OCTA beautifully demonstrated the branching neovascular network with some fuzzy border. We asked for an we asked for an ICG which could see, which showed us there's a there were a bunch of polyps at the end of the neovascular membrane. So we knew there's a reactivation of these polyps, and this gentleman was treated with multiple injections of aflibercept, and we did focal laser to the polyps also. His vision improved to 6/9 and 6. However, there was some residual metamorphopsia persisting. So this is another example where the patient might be having a scarred CNVM in the other one eye and can be having a drusenoid PED in the other eye. Particularly, this drusenoid PED may not cause symptom to the patient, but we need to observe them very closely for development of any early choroidal neovascular membrane. And the symptoms of metamorphopsia in this case helps to identify the symptom. So this is another patient where there might be a double layer sign, particularly seen in PCV. So this particular patient was being followed up for a long time, but when she complained of a metamorphopsia, OCT helped us to demonstrate that there was a presence of subretinal fluid which was responsible for this metamorphopsia symptoms, and all these cases need to be treated with injection anti-VEGF. So coming to the next case, so PFT is another macular pathology, but however, because this is a relatively long-standing condition, so they may not complain of metamorphopsia. But if a patient with PFT can complains of metamorphopsia of sudden duration, we should look for a CNVM, and these cases needs to be treated with injection anti-VEGF. So moving to another interesting case, this was a 60-year-old lady who was a patient of chronic asthma on inhalers, presented to us with sudden onset diminution of vision and metamorphopsia for 10 days. So fundus photograph showed there was a presence of inferior exudative RD. Interesting finding on angiography was there was a large RPE rip with some areas of focal leaks at the edge of the RPE rip. OCT showed the denudated RPE, and because there was a large RPE rip, we preferred the patient to observe, and with time this lady resolved but there was an extensive RPE atrophy with persistent metamorphopsia. This is another case which was a 23-year-old young male, had a history of road traffic accident with head injury, presented to us with vision of hand movement in the right eye and counting finger 2 meters in the left eye. So right eye, the patient had a pale disc, left eye had vitreous hemorrhage, we could see some attached peripheral retina. We initially made the diagnosis of Terson syndrome and planned the patient for vitrectomy. So post-vitrectomy, we could see that the retina, even though the retina was well attached, there was a prominent choroidal scar, choroidal rupture, which was passing through the macula. His vision, though, improved to 624, but he had a very prominent symptom of metamorphopsia. Coming to the metamorphopsia with minimal or no obvious macular pathologies, this is a 61-year-old gentleman came for a routine cataract surgery. He described that he had a poor vision since childhood. His right eye vision was 660 and left eye was 69. Fundus examination showed some mild RPE alterations in the both eye with some early ERM in the left eye. So when we asked for an OCT, we could see there was a very tiny area of focal photoreceptor layer defect in the right eye. Asking retrospectively, the patient gave a vague history of seeing solar eclipse in childhood. Left eye also had a tiny RP defect, though this was a parafoveal with presence of an ERM. So this was a case of photic retinopathy. The patient underwent cataract surgery, and following cataract surgery, vision improved with some residual metamorphopsia. This is a 30-year-old young male who was a high myopic in the right eye, presented to us with sudden onset metamorphopsia of 3 days duration. So particularly, he was very particular that the lines appear waved and curved. So even the fundus, because the fundus was extremely tessellated, there was a hyperpigmented area and the specks of hemorrhage could be seen. His vision in the right eye was 6/9. OCT showed there's a presence of subretinal hyperdeflective membrane. Angiography demonstrated a well-defined choroidal neovascular membrane. So this gentleman was treated with 2 injections of anti-VEGF. His vision improved to 6/6 and metamorphopsia also improved significantly. So this is another patient, 57-year-old lady who complained of metamorphopsia since 6 months. She had no previous history of any trauma or surgery. So the OCT showed there was a tiny macular hole, even though there was some hyperreflective material at the base of the macular hole. At this stage, we were not very sure whether there was a VMT which got released or not. But since the macular hole was pretty small, we decided to observe this patient, and with serial follow-up, we could see that the macular hole got closed with some improvement in the outer retinal layers also. Coming to metamorphopsia with inner retinal pathology, diabetic macular edema is another disease entity which can present with decreased central visual acuity as well as complaints of metamorphopsia. So presence of hard exudates, presence of subretinal fluid, and the disorganized inner retinal layers are thus some OCT biomarkers which are responsible for metamorphopsia in diabetic patients. RVO patients can also present with metamorphopsia. All these patients are usually treated with anti-VEGF injections. However, if you see these RVO patients, particularly even though the macular edema got resolved, the vision was 6/9 partial with some complaints of metamorphopsia because there was some residual outer retinal defect. So even though macular edema resolves, the outer retinal defect can be the cause for residual metamorphopsia. Coming to the next case, it was a 65-year-old lady complains of sudden onset metamorphopsia for 1 week. She was a known case of diabetic hypertension, history of CVA few years back, came with a visual acuity of 6/45. Here we can see there is a well-defined submacular hemorrhage, which the OCT showed the level to be at the level of sub-ILM, and along with it we could see a small area of TRVO. So possibly this was a case of ruptured RAM. We observed this patient. We could see that the sub-ILM hemorrhage got resolved, but this RAM had some exudations around it. At this stage, we planned to inject anti-VEGF, along with we did focal laser to the RAM, and with that follow-up, patient resolved, and with the preservation of the outer retinal layer. So there was a resolution of metamorphopsia. So metamorphopsia due to there are some entities can be metamorphopsia with retinal ischemia also. So in cases of chronic DME, if there are distortion of FAZ, this particular patients can have a long-standing metamorphopsia. They sometimes respond poorly to anti-VEGF and respond moderately to steroid injections. There were some idiopathic causes also. So this was a 17-year-old boy who came with sudden onset metamorphopsia in both eyes for 1 month duration. He gave a history of dengue fever preceding the symptoms. So when we saw the fundus, there was a very mild RP alterations, but this multicolor imaging showed a well-defined area of central scotoma in the eye, which was more prominent in the infrared reflectance, which showed the pathology located more on the deeper retinal layers. So OCT showed there is a attenuated photoreceptor layer in the right eye as well as in the left eye, which was responsible for this central scotoma and metamorphopsia. So this was a case of acute macular neuroretinopathy, and this scotoma, particularly the shape of the scotoma, patient describes and they draws the scotoma in the same way. It involves the OPL and outer plexiform layer and outer nuclear layer. So that particular case previously most probably was a case of resolved AMN. So this will be my last case, which is a 26-year-old man presented with metamorphopsia for last 4 months. Fundus picture was actually non-significant. However, the visual field showed a prominent arcuate scotoma in the right in this eye. His color vision was normal. So when I asked for an OCT, even if we grossly see it might be normal, but if we see here, there was a hyper-reflective inner retinal layer. So we asked for an OCT angiography, and we could see the signal void area in the deep capillary plexus. So this was a case of paravenous acute, paracentral acute middle maculopathy, which involves the inner nuclear layer. So these are the few cases which can present with metamorphopsia. Therefore, to conclude, I would say that the metamorphopsia can be a common yet debilitating symptom of various macular disorders. Many of these conditions are treatable, and if we treat these conditions, we diagnose it timely, and we can treat it properly, the patient recover from the symptoms and gain a useful vision. Thank you.
Yeah, excellent talk, Dr. Kalpita. So I would like to ask Dr. Atul, sir. So in your practice, when you see these vascular patients who come with metamorphopsia, especially in AMD cases, what is the time that you think that they present with metamorphopsia? Is it during the time of presentation when they have a membrane with a lot of fluid, or when they become slightly better?
I think it also depends on the the overall cognitive capacity of the patient, because many of these patients are elderly, and I have seen both categories where patients present very early, in the sense that they immediately notice that they have metamorphopsia. But surprisingly, I have also seen patients who come in for a maybe almost like a routine eye examination, and they don't realize that one eye, the vision is grossly distorted as well as reduced, and it is with the other seeing eye that they are doing a lot of their regular day-to-day activities. So I have seen both scenarios where patients come in early as well as patients sometimes being completely unaware of the disease because of a functional other eye, obviously related to the patient's overall cognitive capacity.
So in say choroidal neovascular membranes, so I have seen in follow-up of patients that initially they have reduced vision, so I don't think they kind of get the metamorphopsia component more. But as they become better in their vision, that's when they start kind of complaining that now it's a little that they're not very straight, or they see the distortion because it becomes more perceptible. So while initiating treatment, so what is the discussion of that we tend to have with the patients who come with vascular causes of metamorphopsia? So Dr. Manvi, can you take the questions?
Yes, so obviously when we come, we have to explain it clearly to the patient that it's not going to be an instant treatment or a one-shot treatment that you are going to receive an injection and you're going to be fine in a few days' time, that it's going to need repeated monitoring, repeated management, and that they have to understand that the visual recovery will be slow, it may be partial, and even in cases where the quantitative vision may improve, they may have qualitative deficits like the contrast may differ or the color saturations differ. These are very often things that sensitive patients, especially the ones with better vision, are more likely to notice in addition to the metamorphopsia, as you very rightly said. So we have to give them realistic expectations and make them understand that it's an ongoing process with ongoing monitoring. Even sometimes after resolution, they may have a recurrence of edema and need treatment again.
Can I make a point?
Yes, sir, please go ahead.
Yeah, so again, as part of this discussion, as you mentioned about the fluid, there's also what one may call, iatrogenic induced metamorphopsia. So, early, even now, patients of CSCR are sometimes treated with focal laser, and less often now, but earlier patients with diabetic macular edema were also treated with focal laser. And I have seen patients who have been successfully treated with the laser, but if the laser burn is significantly dense, then with the improvement of the vision post absorption of the fluid, sometimes the metamorphopsia can be extremely disturbing to a patient. So I've seen, in fact, I clearly remember a young patient who was treated elsewhere with CSCR. His CSCR resolved with the laser, but the laser burns were so close to the fovea that he had constant metamorphopsia, which was extremely disturbing, and it could not be managed in any way. So that can be a cause of early metamorphopsia post successful treatment. And also another thing to be kept in mind in patients who have been treated with focal laser perifoveally, if they start getting metamorphopsia a few months or years later, then one should suspect iatrogenic, laser-induced subsequent choroidal neovascular membrane, which can happen. I've seen in patients with CSCR treated with perifoveal laser and subsequently developed choroidal neovascular membranes at the laser site.
I think Dr. Mahesh has a point. Sir, please.
Yeah, what I believe is one of the things that for metamorphopsia to occur is that the photoreceptors should be functioning well. So if the photoreceptors are already atrophic or they're not functioning well, then patient doesn't notice metamorphopsia. That is the reason acute diseases, for instance, even a vein occlusion can cause actually a serous detachment or a CSR. Those are the patients who are probably likely to complain of metamorphopsia much more. And CNVM, yes, in the initial stages, yes, but over time, what happens? The photoreceptors probably tend to die out, or if there's an atrophy, then they stop complaining of metamorphopsia. So the photoreceptor should be intact, and the acuteness of the event are the ones which cause the metamorphopsia. So the longer the disease has been there, they probably don't complain too much. That's the reason you won't find a diabetic patient complain too much of metamorphopsia as compared to a patient who's got a CSR.
Excellent point.
Sure, sir. Do you have any more discussion, sir, or shall we move on to the next topic, sir?
Just one point.
Dr. Guru has a point.
I just want to add to the long list of Kalpita Das. The fact that recently during the festivals, both Dasara and Deepavali, there were a lot of processions with laser shows of processions of deities and a lot of young people participating and a lot of laser light being shown around. And we have had incidences of sub-ILM hemorrhage right at the fovea because of exposure to the laser light. That is what we presume. The common factor amongst the 5-6 patients that we came across was the exposure to the laser light. So this is one cause. The sub-ILM hemorrhage can also be caused by laser light, which probably is an unregulated laser, a very dangerous laser that has no regulation in terms of safety measures and all that. So we have to remember that when we see a sub-ILM hemorrhage in a young patient. Yeah.
Sure. Yeah. Thank you, Guru sir, for the very important insight and one of the very rare kind of presentations, but right now being more and more observed. Thiru sir, do you want to summarize or?
No, I think we'll go ahead with the next one and then we'll summarize. I think time also is running.
Yeah. So thank you, Dr. Kalpita. So then next presentation would be by Dr. Partho Pratim. And the topic of presentation is triage and management of inflammatory metamorphopsia. So switching gears and going to a UVI related topic. Yeah. So can we play the Dr. Partho Pratim's video, please? AV team. Kripal sir.
Oh, I think Dr. Partho is probably not.
No, Dr. Partho had sent his videos. So
okay.
Yeah. I would request AV team or Kripal sir to please play the video.
I'll just play.
We'll just play, no?
Good evening, everyone. I thank Dr. Divyansh Misra and Dr. Santosh Honavar sir for having me in this unique webinar. I am here to give you a perspective on inflammatory metamorphopsia. Metamorphopsia in uveitis patient can be compared with the bass guitar in a rock band. While the bass guitar is crucial for rhythm and harmony, it is often overshadowed by the lead guitars, vocals, and drums. Similarly, many uveitis patients experience metamorphopsia, but it is often overshadowed by the symptoms such as photophobia, eye pain, and floaters. So sometimes paying attention to these symptoms such as metamorphopsia can help the clinician to clinch a diagnosis in a busy clinic. So the talk is divided into 3 parts. The first part will deal with metamorphopsia in the background of major uveitic manifestations. The second part addresses the conditions that are primarily characterized by metamorphopsia, meaning conditions where metamorphopsia may remain predominant presenting symptom. The last part will trace metamorphopsia to uveitic complications, not the primary inflammatory episodes. So to start with the entities, the Vogt-Okwanagi-Harada disease, sympathetic ophthalmia, posterior scleritis are some conditions where symptom of metamorphopsia is often masked by other severe or acute symptoms such as headache, eye pain, etc. But sometimes, specifically in the very early stages of the disease, metamorphopsia can be the initial manifestation of these particular diseases. The problem is our understanding and knowledge of these entities. These are so closely associated with common symptoms of the disease such as headache, eye pain and all, that a case of posterior scleritis or VKH can be missed easily if a patient presents only with metamorphopsia in the very early part of the inflammation. I'm sure such a dedicated webinar may be helpful to eliminate such bias. VKH is a panuveitis associated with multisystem involvement where there is T lymphocyte mediated aggression to melanocytes in eyes, meninges, ears, and skin. The condition is characterized by prodromal phase, characterized by viral-like illness, usually associated with headache. Patient can often complain of metamorphopsia and scotoma in the very early stage when there is very early manifestation of subretinal fluid accumulating at the posterior pole. So the associated symptoms like tinnitus, vertigo, headache often helps to clinch the diagnosis during this early period. VKH is characterized by granulomatous anterior uveitis and vitreitis can be moderate to severe. The ultrasound B scan is helpful and shows diffuse choroidal thickening, serous retinal detachment, and OCT can show that the subretinal fluid seen during this acute stage can be divided into multiple compartments by inflammation-induced fibrous septa, creating this multilobular configuration or arrangement. Now, the fundus fluorescent angiography is helpful and shows pinhead leak in the early stage of the disease angiogram and followed by a placoid pulling of the dye. However, such fundus fluorescent angiography finding is not specific to VKH and can be seen in various other conditions, including posterior scleritis, sympathetic ophthalmia, etc. The sympathetic ophthalmia is a classic model for autoimmune disease where posterior segment intraocular inflammation develops after sensitization to previously sequestrated ocular antigen. So any ocular insult which may have led to uveal incarceration can lead to sympathetic ophthalmia. Often the disease can manifest only with metamorphopsia and pain while doing near work like reading and writing at the early stage of the inflammation. The presence of cyclitis thus a very unique feature of sympathetic ophthalmia, and anterior segment may show nil to minimal congestion with vitreitis and variable amount of subretinal fluid in the fundus. Now, the incidence of sympathetic ophthalmia has greatly increased after surgical procedure. Almost all kind of procedure has been linked to develop sympathetic ophthalmia, but most common risk is after multiple vitreoretinal surgeries. This 28-year-old male who underwent multiple vitreoretinal surgeries following rhegmatogenous retinal detachment in his right eye presented with metamorphopsia and diminution of vision and was subsequently diagnosed as sympathetic ophthalmia. So if you can diagnose this condition early, one needs to treat this condition with pulse corticosteroid and immunosuppressives, and the responses are usually very favorable, and one can prevent bilateral vision loss in patients with sympathetic ophthalmia. Now, another entity is posterior scleritis, which remains the most misdiagnosed treatable conditions in ophthalmology. The posterior scleritis has plethora of manifestation, and rarely patient may present with complaint of metamorphopsia when there is a macular involvement by subretinal fluid. So this kind of situation is more common in children compared to adult. And usually the posterior scleritis is associated with ocular pain. However, we did a study which showed that approximately 23% of the patient, the pain can be absent or very minimal. So one can order ultrasound B scan to see the outer coat thickness in such suspected patients. Also, one should understand that T sign, though help in the diagnosis of posterior scleritis, is not mandatory for the diagnosis of the clinical condition. Now, these are the conditions where metamorphopsia may come in forefront of focus of all presenting symptoms. The list is long and consists of few closely associated clinical entities. So for the interest of time, we'll discuss or concentrate on the commonest clinical entities here. Two quick important points I want to highlight here. The number one, all these conditions, the patient may complain of photopsia in addition to metamorphopsia. We all know that the photopsia is a visual disturbance, a flash of light that happens without any light source. So the second important point is majority of these conditions, the clinical lesions may be very subtle and require additional imaging to clinch the diagnosis. Now, coming to our first entity, the macular serpiginous choroiditis is an important cause of metamorphopsia. The active disease begins with the ill-defined patches of grayish or yellow cream subretinal infiltrate-like lesions originating in the macular area, and the active lesions resolves over 6 to 8 weeks, leaving an area of pigmentation and chorioretinal atrophy. So the disease can be insidious, with many patients presenting with no symptoms until the macula is involved. So also the patient may have a higher risk of choroidal neovascularization. In fact, any patients with healed macular choroiditis patch complaining of metamorphopsia should be investigated to rule out inflammatory CNVM. Now, metamorphopsia can also occur in foveal involvement in multifocal choroiditis. Photopsias are often much more disturbing than other white dot syndrome than in like multifocal choroiditis, and this kind of metamorphopsia and the photopsia may persist even after the scarring of the lesions. Now, anterior uveitis is present in multifocal choroiditis in up to 50% of the patient, and vitreous cells are very common. The choroidal lesions are numerous and often yellow and yellowish gray in color and round and oval in the nature. The lesions are commonly seen in the peripheral region, in the posterior pole, and in the mid periphery. So as the lesions resolve, they become atrophic and can appear punched out with varying degree of the pigments outside or within the lesions. Now, the CNVM can occur in the 1/3 of the patients with multifocal choroiditis. So one has to be really careful while dealing with a patient who has a healed multifocal choroiditis and macular involving scar, but the patient complains of sudden onset metamorphopsia. Now, the most common symptom reported from the punctate inner choroidopathy are metamorphopsia, paracentral scotoma, and photopsia. Now, PIC, commonly we call it, is characterized by the absence of inflammation and presence of multiple small yellow or white opaque and round lesions scattered throughout the posterior pole, and the PIC is typically bilateral, can be asymmetrical, and it affects young myopic females mainly, and mainly they are frequently can be associated with CNVM. Now, RP epitheliitis is characterized by acute onset of painless loss of vision, central scotoma, and metamorphopsia. So, acute RP epitheliitis is considered as a rare disease, but its prevalence likely to be underestimated due to the difficulty in detecting these very subtle dots at the level of the RP, and also due to the transient nature of the disease. The fundus examination reveals the gray spots at the level of RP surrounded by a yellowish halo with a indistinguished border. Now, a simple fundus autofluorescence can reveal slight increase in the hyperautofluorescence of these lesions corresponding to this white yellowish or whitish dots. And OCT can show abnormal foveal hyperreflectivity involving the outer nuclear layer and photoreceptors. And the RP can be disrupted in 75% of the patients also. Now, in third segment of the talk, we'll discuss causes where complications of the primary inflammation is responsible for the metamorphopsia. And one should be careful if a patient with healed uveitis or a patient of uveitis receiving corticosteroid comes back with a simple complaint of metamorphopsia. We should not underestimate, and we'll see why we should not underestimate such a cause of metamorphopsia. This 28-year-old young man sustained an ocular injury in the right eye and underwent corneal tear repair, but lost vision in the eye and became perception of light negative. He presented with diminution of vision, metamorphopsia in the left eye after 10 days, and was seen by a local ophthalmologist and diagnosed as sympathetic ophthalmia. His anterior chamber and anterior vitreous was white. Fundus examination revealed subretinal fluid over the macula, which was confirmed again in an OCT, which the patient was carrying. So we did a FFA and realized that it was a case of central serous chorioretinopathy and not a case of sympathetic ophthalmia. So sometimes the patients are so anxious, and especially in type A personality, this kind of phenomena can occur. So the clinician must be aware of such situation associated with metamorphopsia, as the treatment modalities of CSR and sympathetic ophthalmia are paradoxical, and one can burn finger if they misdiagnose such a situation. Now look at this fundus photograph of this young girl who presented with diminution of vision with metamorphopsia in both eyes, and this can be confused with serpiginous choroiditis. Until and unless you perform a FFA, and in this case, FFA picked up that it was a case of multiple leak CSR, not a case of choroiditis. Now, inflammatory CNVM and CME are just like pouring the salt on a wound, as the development of CNVM and CME in a patient with uveitis intensifies the patient's suffering or ocular morbidity. Now, these are the conditions you need to manage very aggressively. CME can occur in any case of uveitis. Any patient with uveitis with metamorphopsia should be examined meticulously for cystoid macular edema. CME can occur in anterior uveitis and most commonly seen in intermediate uveitis. So, in other words, it is also important to examine the pars plana area of a patient who presents with metamorphopsia secondary to cystoid macular edema. Now, one should not ignore metamorphopsia in patients with Hill choroiditis. Detection of CNVM by clinical examination is often difficult because of the presence of the choroiditis scar, and one may miss such dreaded complication if an OCT is not performed. Now, management of metamorphopsia secondary to inflammatory etiology remains little tricky. One should always take a meticulous history of prodromal features like febrile illness, presence of tinnitus may help us to give a clue towards the diagnosis of VKH. History of surgical procedure in other eye may help in the diagnosis of sympathetic ophthalmia. And though many cases of uveitis, the ocular pain and diminution of vision takes over the symptoms of metamorphopsia, paying special attention to these symptoms is must. For example, history of pain with eye movement may be a feature of posterior scleritis. So, as I have shown in some case scenarios, imaging plays a significant role in the management of such patients. Pulse corticosteroid is a shot of choice when you want to prevent the vision loss in macular encroaching choroiditis or in similar lesions. The people should remember the cases of serpiginous-like choroiditis where we need to rule out ocular tuberculosis etiology. And also many such patients with inflammatory cause of metamorphopsia needs long-term control of primary inflammation, which can be benefited by the use of immunosuppressive. One such classical example is inflammatory CNVM with the injection of intravitreal anti-VEGF agents. And monitoring the response, one must ensure that the effective control of inflammation has been achieved. Similarly, in a patient of uveitic macular edema, if a proper control of uveitis is not achieved, the patient will continue to develop recurrences of macular edema in spite of repeated intravitreal steroid injection. Thank you for your patience hearing.
Yeah, thank you, Dr. Pata. It was a very nice presentation. So, just two questions out of the whole presentation. One, how would you want to triage or differentiate a CNVM versus PIC lesion? So, the question goes to either Dr. Manvi Madam or Dr. Atul if they want to take up. How would you want to differentiate a case of PIC or a punctate inner choroidopathy versus CNVM, because that both can be present in a high myopic patient?
So I think one of the very useful tools in the modern era is OCT angiography in such cases. Even actually, I was thinking when the presentation just now showed the occurrence of a secondary CNVM in healed choroiditis, even in those eyes, an OCT can be very difficult to interpret because you have these areas where there's scarring and there's thinning and atrophy. And in such eyes, having an OCT angiography can really help you diagnose and pick out that vascular membrane and help you clinch the diagnosis.
Yeah, thanks very much. So OCTA is very helpful in such cases. Dr. Pata, do you want to add something to it?
Yeah, very, very correct. Actually, OCTA really helps in the diagnosis. And sometimes, the problem is you ask this question that peak or differentiate between C and VM, but the problem is, many a time both the condition can come together. Like the peak is entity which is very notorious to develop C and VM. I think Dr.
Sure.
Ramandeep.
Yeah.
Yes, sir.
Dr. Majumdar, it was a good one. Good talk. I had few points. I think because OCT angiography, everybody will not be having it. I think it's important to have a OCT scan, which is a dense scan. If we do a radial scan or a line scan, your CNVM will not be picked up. All right. Like Dr. Majumdar said, because I believe when the patient's vision is already poor, like this macular choroiditis scars are already there, he may not complain of metamorphopsia sometimes, all right. But good slit lamp biomicroscopy, picking up hemorrhages is very important, and getting OCT for them at every visit is important, because and you need a dense scan. That is very important. That is the one point I want to add. If you don't have Octa, do a dense scan. Yeah. Thank you.
Thank you, sir. So one more question which I would want to ask is, how would we differentiate between an active serpiginous choroiditis and having, or either an activation or an occurrence of a CNVM at that edge? So in those cases, how would we want to manage? Would the imaging change in certain way, as Dr. Amandeep told, only consider a dense OCT, or whether other modalities of the management would also come into play? So Dr. Guru Prasad or Dr. Mahesh can also take the call.
Yeah, I think Dr. Ramandeep has already nailed it. Clinically, don't miss hemorrhage. Do a 90-day examination with high magnification and look for hemorrhage. It may be rare, but sometimes you do find it. Secondly, a dense OCT scan, and if you have Opta facility, you can definitely pick up a network if it is a CNVM. But on an OCT, it is rare to find cells in a serpiginous choroidopathy, because the vitritis is hardly anything, hardly any in terms of severity. It won't be there. So you don't see cells in serpiginous choroidopathy. I think these are the points that I wanted to say.
Sure. Thanks. So as Dr. Partha has also suggested in his presentation, or the first slide, that how to triage, we have to look in for the other adjuvant signs like photopsias or associated signs, like if the patient is having redness of eye, pain, and other associated signs, and associated modality should be utilized, like OCT, a dense OCT scan at that particular area, as Dr. Ramandeep suggested, or an OCTA. And yes, very important, the age-old FFA is also helpful in those cases to diagnose and manage cases. So in such cases, it's very important to consider this kind of invasive managements also. So going on to the next presentation, which is not a very common kind of a presentation, but is always a masquerade. So the next presentation would be by Dr. Vishal Rawal, and he would be taking triage and management of neoplastic and miscellaneous related metamorphopsias. Yeah, Dr. Vishal.
Yeah. Thanks, Divyansh. Thanks to Dr. Honavar for the kind invitation. I hope my slides are visible and it is in slideshow mode. Okay, thank you. So yes, so after hearing the previous presenters, I think most of us will be aware of most common causes of metamorphopsia. And being a retina and ocular oncologist, I'll be kind of delving into few very uncommon causes of metamorphopsia. And let's see, as a retina specialist, you need to be aware of some uncommon causes and how we need to diagnose and treat this uncommon reasons for metamorphopsia. So I will not go more into kind of detailing. As you can see, it was kind of first elaborated by Foster, but the Amsler in 1950s was the first person who kind of came out with the Amsler's chart and the grid, and the definition was kind of a device where the patients usually pursue this quality of vision going down, and usually complaining of deviation of the vertical or horizontal lines, which is usually reported by the Amsler's grid. Directly delving into my topic, which is relevant to this presentation, is the neoplasia, various entities, and how it impacts on the vision in terms of relation to metamorphopsia. So the tumors, usually what I am going to delve is Benign tumors, again, you have to kind of segregate into where it is arising, whether it is a retinal tumor or a choroidal tumor. And similar for the malignant tumors, whether it is a retinal origin or choroidal origin. And few entities kind of miscellaneous, which doesn't fit into any of this classical description. So the main mechanism why you will see a metamorphopsia, particularly in the case of neoplasia, is particularly if the tumor is arising from the choroidal compartment, you will see there will be a mechanical compression overlying the retina or the outer or the inner retinal layers, and that might lead to metamorphopsia. Sometimes the tumor might be arising from the retinal compartment, where it might lead to kind of swelling in the retinal layers, or sometimes it might lead to traction, which will be in and around the fovea or the parafoveal area, which can lead to metamorphopsia. Sometimes the tumor might not involve the macular area, particularly the reason for metamorphopsia, but the tumor might be active, it might be leaking, and it causes the kind of segregation of the fluid into the foveal or the paramacular area, causing neurosensory attachment, and the patient might turn up with the complaint of metamorphopsia. Very rarely, sometimes the compression of visual pathways, and as was elaborated in the previous presentation, ischemia, particularly in the macular area, can also very rarely lead to metamorphopsia. So I'll directly go into a few important cases related to the topic. So this was a 21-year-old male who complained of blurring of vision, particularly for the distance, associated with some distortion of objects in the right eye for 4 months. As you can see, the vision in the left eye was 20/20 N6, in right eye was 20/25, parts with N18. As you can see on a clinical fundus photography, left eye was absolutely normal. In the right eye, you could see there is a smooth dome-shaped elevated lesion, particularly arising from the choroidal layers. As you can see, the overlying retinal vessels are absolutely normal. Looking very closely, you can see this lesion is kind of 6 to 7 disc diameters in size, more kind of horizontally elevated as compared to vertically. Also, you could see there is a kind of cuff of subretinal fluid seen in around the lesion. So in oncology, usually 90% of cases you make a clinical diagnosis. And looking at the configuration of the tumor arising from the choroidal compartment associated with tumor SRF, which was leaking into the foveal area, and the orangish color lesion, I think the diagnosis was kind of clear-cut, where we're looking at a case of circumscribed choroidal hemangioma. Important point for the circumscribed choroidal hemangioma is to do imaging. First, to do a good B scan to document the tumor configuration, tumor size, and also to do the corresponding A scan, which will show high surface reflectivity and medium to high internal reflectivity, which is very classically seen in cases of circumscribed choroidal hemangioma. OCT is very important. Again, it shows a very smooth dome-shaped elevated choroidal lesion with presence of compression of overlying choriocapillaries and presence of subretinal fluid seen not only overlying the tumor but also at the edge of the tumor, and this suggests that there is the activity. Fluorescein angiography is not usually required, but yes, in cases where there is a diagnostic dilemma, fluorescein angiography as well as ICG angiography does shows increased pinpoint hyperfluorescence in early to mid to late leakage in the late phases. So diagnosis in this case was kind of confirmed with the imaging as well as your clinical observation. Because of the height of the tumor more than 4 millimeters, this patient underwent right eye plaque brachytherapy. We have ruthenium-106 isotope with 40 grays given to the tumor base at a height of 4 millimeters. Post-treatment, you could see there was a symptomatically patient was happy, the vision had improved, the metamorphopsia has decreased. And similarly, you could see the height of the lesion has also started reducing, or the tumor has started reducing. The SRF component, which was kind of leaking into the fovea, the macular area, has also kind of reduced. And this was confirmed again on your OCT, where you could see pre and post OCT, the amount of SRF has reduced, and even your B scan, the height of the tumor has started reducing. But to surprise, post 6 months down the line, you could see there were small cotton wool spots with few retinal hemorrhages. And particularly in a patient who has undergone radiation treatment, particularly plaque brachytherapy, where the tumor is so close to the fovea or to the optic disc, you invariably are going to deliver a high radiation dose to these important vital structures. So at this stage, even though there was no evidence of any cystoid macular edema, patient was kept under observation. And 3 months down the line, now the patient presented with again metamorphopsia. So I think that as a ocular oncologist, you want to deal with two important things: whether there is a reappearance of the tumor, or the tumor has again started leaking, or if the treatment what you have done, plaque brachytherapy, has not worked, or there is a sequelae of the disease, particularly to treatment what you have done, that is plaque brachytherapy, and now it is showing effects of radiation retinopathy, as you can see in this fundus photograph, as well as the OCT. And this patient ultimately underwent 4 intravitreal anti-VEGF injections. Despite that, there was not much improvement in the vision, and the edema also didn't respond as it was in any case of DME or vascular occlusion. So we know these patients have a chronic kind of macular edema which doesn't respond to anti-VEGF injections. And I think we are kind of into a scenario where a prospective DRCR network trial has been kind of initiated to look into treatment for radiation retinopathy. Coming to second case, this was a young girl, 9-year-old girl, complaining of vision kind of distorted and some alphabets missing. And on visual acuity also, it was 20/60 parts. This was a case which I had a very diagnostic dilemma. I didn't know what it was unless I had kind of opened the gas atlas, and there I could see this case resemble one of the case which was reported in the literature. So on close observation, you could see there is some kind of pigmentation seen in the parafoveal area with some kind of fibrosis. OCT, at that time, I didn't know what it was, but then looking through the literature, I came to know, okay, this is a very, very classical appearance of congenital simple hematoma of retinal pigment epithelium. And the OCT, you could see there's a hyperreflective layer which is seen, which is very in cases where the RPE kind of migrates not from the outer retina to the inner retinal layers, and you can see this characteristic cap-like sign with posterior shadowing. The diagnosis, yes, was made, but as the patient was symptomatic and the traction at the fovea was kind of significant, after thorough counseling with the parents that the vision might not improve despite removing this entity, the patients agreed and we did the surgery. And we did send the histopathology for this specimen, and it again kind of confirmed our diagnosis of congenital simple hematoma of retinal pigment epithelium. Post-treatment visual acuity kind of stabilized to 20/60, but the OCT, again, it showed the resolution of the tractional component, but the foveal thinning as well as the disruption of the outer retinal layers, especially photoreceptor layers, made sure that the visual acuity kind of stabilized at 20/60. Third case, here again the patient complained of distortion of objects in the right eye for 2 months. Visual acuity was 20/40 and 10. And you see this classical appearance of an epiretinal membrane kind of thing, which is kind of seen over the surface of the retina, which is usually seen at the posterior pole involved in the macula and the parapapillary area. From a retina specialist point of view, usually you make a diagnosis of epiretinal membrane, either it is idiopathic or it is inflammatory. But I think looking closely to the OCT, I think then you can cleanse the diagnosis, you know what you are dealing with. In epiretinal membrane, I think the etiology or the membrane kinds of limits itself to the inner retinal layers. But whenever you see this kind of OCT, where you see classical kind of infolding of the retinal layers with preretinal fibrosis, with classical description of omega sign, I think you know you are dealing with a case of combined hematoma of retina and retinal pigment epithelium. And these cases, I think the retina specialist needs to be kind of very sure when they are kind of distinguishing between a idiopathic or inflammatory epiretinal membrane and combined hematoma, because these cases, if you undertake for surgery as a simple epiretinal membrane removal, it can be disastrous and it can lead to significant visual loss. So this patient, once it was diagnosed, we kind of planned to observe this patient, and over the 1 year, you could see the visual acuity kind of remained 20/30 and 8, and there was no evidence of any distortion or even kind of puckering causing a significant visual rehabilitation. Fourth case, this was a 13-year-old female girl, came only for a suspicious lesion seen in the left eye by a general ophthalmologist. Visual acuity was absolutely normal in both the eyes. You see this lesion, again, in oncology, you make a clinical diagnosis. This is choroidal osteoma. Just for the audience sake, you do an B scan. Again, it shows a linear hyperreflective lesion seen in the choroidal with posterior shadowing, which is very, very classical description of osteoma. We usually don't treat these lesions, usually observe. Usually these are seen in young girls, particularly at the age of puberty. Whenever there are any hormonal changes, there is an added risk of either choroidal neovascular membrane seen at the edge of the lesion, or sometimes these benign tumors can grow. And then you see this patient coming back in 6 months' time with drop in vision. And you could see the pre and post fundus photograph, if you can compare the small tongue shape elevation, you can, or the growth of the lesion towards the fovea with neurosensory attachment of the subretinal fluid, which is very clearly demarcated in the fundus photograph. You do an OCT through this lesion, you will see presence of subretinal fluid. So now you are dealing with a case of a benign choroidal osteoma, which has started growing for whatever reasons. Usually it is something related to hormonal imbalance or at the age of adolescence or puberty, where you see sometimes these benign tumors can grow. For this patient, we don't have PDT at present right now. So we went ahead and did transpupillary thermotherapy to the edge of that growing tumor. And you could see a beautiful resolution of the lesion, where you could see there was the SRFS reduced. There was scarring seen at the edge of the lesion, and the OCT again kind of restored with no evidence of any subretinal fluid or any growth of the tumor. Sometimes retinal lesions can also present with metamorphopsia or distortion. This is one case. Again, you see this multiple subretinal yellowish lesion with multifocality, presence of leopard kind of spots or pigmentation. You make a clinical diagnosis of primary vitreal lymphoma. Important feature is the OCT, which will help you to cleanse the diagnosis, where you will see multiple RP undulations with classical sub-RP infiltration, where the lymphoma cell infiltration happens. In this case, the lymphoma cell infiltration, even though subclinically you could see it was not involving the fovea, but the OCT lines can through the fovea or the macular area show this presence of classical sub-RP infiltration. And this patient underwent 8 injections of intravitreal methotrexate with beautiful resolution of all the sub-RP lesions, and even the OCT showed nice resolution of sub-RP infiltrates. Next case, this is a case which was again referred for bilateral choroidal elevated lesions with progressive diminution of vision associated with flashes and floaters. So you see this patient, again, kind of orangish lesion, kind of abutting the fovea in the right eye. In the left eye, there were 2 small orangish lesions seen in the inferior retina. Differential diagnosis: in a case of any orange color choroidal lesion, you know you are dealing with metastasis, usually either from the carcinoid tumor of the lung, renal cell carcinoma, or thyroid carcinoma. Usually all the choroidal metastasis usually resembles yellowish color, except these 3 tumors which will metastasis to the choroid in orange color. So you need to differentiate whether any of these 3 primary tumors have metastasis to the choroid. Very rarely, yes, benign tumors, choroidal hemangioma, you need to rule out because these are also orangish tumor. Amelanotic choroidal melanoma, again, a very important entity seen in this part of the world, where we usually see choroidal melanoma being non-pigmented, and very rarely it can be leiomyoma and schwannoma, which are also a kind of non-pigmented choroidal lesions. So this patient, we made a provisional diagnosis of choroidal metastasis, possibly primary from the lung, and chest CT again kind of confirmed our diagnosis. We went ahead with a transvitreal fine needle aspiration biopsy, which showed high-grade neuroendocrine small cell lung carcinoma of carcinoid origin. And this patient underwent palliative ocular radiation, 24 grays to both the eyes, and you could see beautiful resolution of both the choroidal lesions and the absence of any subretinal fluid. Next case is of a female patient of 61-year-old with a possible bump in the macular area. And this was one entity which I didn't know anything about this entity before, until and unless we saw 2 cases when I was doing my fellowship in US. And there I learned about this entity known as choroidal macrovessel. So usually you will see this kind of small yellowish kind of vessel which is dilated in the foveal or the submacular area. Your ICG will show characteristic pinpoint leakage, which is very, very limited to that vessel. OCT will be very, very important, which will show a nice dilated choroidal vessel, which will cause a kind of small bump in the overlying retina. And usually these patients might be kind of having a subtle distortion of the objects, and the general ophthalmologist might have been worried about some kind of choroidal lesion or choroidal melanoma or hemangioma, and usually these patients are referred to the oncologist. So usually choroidal macrovessel is a single small hypopigmented tortuous dilated vessel, which usually seen at the posterior pole, usually extending from macula to the equator. 90% of cases it is always unilateral, and the origin still it is kind of not sure, but through our review of literature we kind of made a hypothesis that usually it is a dilated physiological vessel, probably posterior ciliary artery, and it remains usually asymptomatic. However, it needs to be kind of differentiated from various nematodes which can have a similar resemblance on clinical examination, choroidal hemangioma, or some pachychoroid diseases. So this patient was diagnosed of right eye choroidal macrovessel, and we kind of observed, and over the 1 year, there was no change in the vision or in any kind of involvement of the surrounding fovea or the macular area. Last thing about the systemic side effects of anti-cancer agents. So this was one case which was seen by our colleague, where both the eyes patients was already on immune checkpoint inhibitors. As you know, I think this is something in last 5 years we are seeing many patients, particularly with lung cell carcinoma, which are not responding to the current standard care of line of chemotherapy. They are started on immune checkpoint inhibitors, and this patient was a case of cutaneous melanoma which was metastasized, and this patient was started on ipilimumab and nivolumab. And post treatment, you could see there was presence of multiple neurosensory like detachment, usually seen any case of uveitic, particularly like VKS like entity. And the history clinched the diagnosis, where the patient had a underlying systemic malignancy, cutaneous melanoma, already on anti-cancer agent, that is immune checkpoint inhibitors, which are very notorious to cause this kind of inflammatory or uveitic like conditions. And post treatment with discontinuation of the immune checkpoint inhibitors and starting oral steroids, I think it resolved beautifully. Last case, this was again a case of tamoxifen induced side effect, where usually it presents bilaterally, very resembling a case of parafoveal lateral telangiectasia, where you could see mild graying in and around the fovea area with multiple crystalline like deposits seen in the parafoveal area. OCT again shows foveal cavitation with small outer retinal layer damage as seen in parafoveal lateral telangiectasia, and OCT angiography usually shows ischemia or the small irregular telangiectic vessels seen in deep capillary plexus. And these patients usually, whenever even they stop tamoxifen, the disease doesn't reverse as was seen in case of immune checkpoint inhibitors. So as ocular oncologist, I think you need to be aware of few conditions or few chemotherapy related drugs which can cause side effects in the eye. Unless and until you are aware, you will not be able to pick up. So the good clinical history, awareness of the clinical condition, and early stoppage of these drugs can cause a mild reversal of the disease. So I will summarize, I think tumors, as you know, they are not very common causes of metamorphopsia, but I think once you rule out most common cause of metamorphopsia, as was elucidated by previous presenters, I think neoplasia, I think remains a small segment of disease where the patients might present with metamorphopsia, particularly not the tumor directly involved in the macula, but sometimes the tumor might cause leakage, which might involve the fovea or the parafoveal area, and then the patients may present to you. History, again, it is very important in oncology. You need to elucidate in detail what kind of presentation they have, what kind of features they have, what medicines they have, any family history. So I think that is very important. And last but not the least, I think metamorphopsia can be an early indicator of tumor growth or presence of SRF in the macula, and thorough clinical examination and ancillary imaging in few cases might help us to clinch the diagnosis. Thank you.
So thank you, Dr. Vishal. Endless topic for being a ocular oncologist. Yeah, very good, and covered all the topics which are related and as a rare presentation of metamorphopsia. So very important was the second last slide. So my question was how to identify or differentiate a PFT, because a PFT can also present as metamorphopsia versus a tamoxifen toxicity. So Dr. Mahesh, Dr. Guru Prasad, so do you want to take the question? What would be the pointers towards a case presenting as PFT? Or yes, history of tamoxifen intake itself is a big history, but other than that, whether there are any pointers to differentiate between the two lesions or the diseases?
I think the OCT finding of macula is unmistakable. The thinning of the retina, the island break sign, the subsidence sign or the collapse sign. These are all, I think, unmistakable signs of macula, which we don't see in. Frankly, I have not seen a tamoxifen maculopathy, but I have seen the atlases and textbooks where we find these pictures, and I don't think they have any semblance to, at least OCT wise, to the macula.
So Any other suggestions by Ramandeep sir or yeah, please go ahead, Manu. Yeah.
So many years ago, we had seen actually a case of a lady who had received tamoxifen for carcinoma breast, and she also happened to be a diabetic, and she had these crystals in the macula, and was referred to the clinic actually on a suspicion of MACTEL. But the OCT is very distinct and very different. So we have all those subsidence of the retinal layers and all those signs. You won't see those usually in a tamoxifen maculopathy, and you may just find a few small cystic changes or a few hyperreflectile spots which are suggestive of the crystals in them. So that is where it can help you clinch the diagnosis.
Just want to add one point, Vishal, great talk. In between your talk and Dr. Majumdar talks, we have to remember that there is something called choroidal granuloma also nowadays, which is we commonly see in TB and the sarcoidosis patients. They also present like, look like tumors, though most of the times they come to us with the hemangioma diagnosis and all that. I think the acuteness is the one which clinches the diagnosis, and then look out for the cells there actually. So sometimes, you don't find cells in the AC, and here where the OCT gives you the clue that there are cells in the posterior vitreous, because sometimes the granulomas are posterior uveitis, so you don't see the cells with the help of clinical examination, but you are able to see with them the OCT. So always make sure to see that vitreous above the lesion. Is there any cellular breakdown or not? I think granulomas has to be ruled out in all these cases actually.
Very true, sir. Very true. Very true. So, Dr. Mahesh, your take on that, sir?
On what, Dr. Divyansh?
Regarding the PFT and tamoxifen toxicity is what you were discussing already. Manvi sir and Guru Prasad sir were of the opinion that usually we don't see the kind of changes what we see in PFT, like the subsidence or the collapse of the retinal layers and the blood vessel changes. So, any more pointers to that? Differentiating a tamoxifen versus PFT.
It can happen, but in PFT, of course, CNVM happens. In tamoxifen, if I remember right, I don't think a CNVM occurrence has been documented as a complication. And pigmentary changes are much more obvious, and the pigment passing through the whole thickness of the retina happens in PFT, which is not very common in tamoxifen.
Tamoxifen, yeah. So
one other tumor which we often causes metamorphopsia, but though it's not in the macula, would be a retinal hemangioblastoma. The tumor can be somewhere in the periphery, but there can be an exudative macular detachment, for which the cause cannot be found out. Like the only clue can be the dilated vessels which are going from the posterior pole towards the periphery. So the tumor will be absolutely distinct, but there will be a neurosensory detachment of the fovea. That's something which we need to keep in mind.
Sure. Sir, Tirumalesh sir, you wanted to add something, sir?
Yeah, tamoxifen retinopathy never has a telangiectatic vessel, but PFT usually you will find a telangiectatic vessel. So Octa either will show you that, or in the OCT you will definitely find that telangiectatic. Tamoxifen does not have that.
The right angle veins, right angle vessels, and the pigmentation, like Mahesh sir said, I think these are the two other differentiating features. The halo and the crystalline deposits are somewhat common to both.
Common to both of that, yeah. Yeah, Dr. Vinod.
I think when we talk about tamoxifen, retinopathy, and MACTEL, so they are common differential when we see them on OCT. So that is the most important thing we should remember. The OCT features of both look like each other, but if you see the other features, for example, if you do FA, like Thiru said, we do not see parafoveal leakage and telangiectasia in tamoxifen, which is in fact a hallmark feature of parafoveal telangiectasia. And all said and done, very good presentation, Vishal. One thing I would like to emphasize is that when we are talking about any cause of metamorphopsia, so one important fact is that anything which leads to accumulation of fluid in the retina or beneath the retina will lead to metamorphopsia. So it is very important that whenever we find fluid inside the retina or beneath the retina, we do a thorough examination of the retina to look for any cause which can lead to fluid. It may be in the choroid also. There are several other entities which may not have been covered. For example, Coats disease. Coats disease in periphery can lead to macular exudation. So all these causes should be kept in mind when we are assessing a patient with metamorphopsia.
Great points.
Sure, yeah. No. Okay. And one more point which we had missed out is probably a VPTR, where there can be a peripheral lesion and then there can be an exudation and detachment at the fovea. So yes, it's an endless list. We cannot cover everything and anything. So the next presentation would be by Dr. Pulkit, who was my colleague when I was doing my post graduation at JSS, and right now he's at Salisbury, UK, and he would be dealing with the topic which none of us have probably so much experience in, and his presentation would be on triage management of cerebral metamorphopsia. Yeah, Pulkit, so take us beyond ophthalmology. Pulkit, we are able to see your slides. You are on mute. Pulkit, we are able to see your slides on slideshow mode. You are on mute. Yeah.
Hello, sir. Sorry,
Right.
it's just
Sure.
a bit
Yeah.
of a glitch. Can you
Okay.
hear? Can you see the
Yeah.
slides? Can you hear
Yeah.
me?
Yeah. And we are able to see you also. Yeah.
Just a second. Let me just.
Yeah, the slides are moving. I think it's gone to the next slide, hopefully.
Yeah, I just.
So, Dr.
Sorry,
Pulkit,
I'll just.
having some issues starting the presentation, is it?
Yeah, sir. I'll just give me a minute. I'll just reload it.
So, I would just want to ask one more question to the panel or the chairpersons, is that what would be the red flags to look in when we are seeing a mass lesion? So how or what would be the signs to say that it is probably a tumor or a metastasis? So Dr. Mahesh or Dr. Guru Prasad or Dr. Atul, so what would be the red flags or what would be the signs to look in for a case where you have a mass lesion, so that we should think in a perspective of a tumor or a metastasis?
Now we're saying if it's a primary tumor or a secondary tumor.
So any lesion in the eye which is causing a fluid, either a metamorphopsia or probably a lesion which is inside the eye, which should give us an indicator that it is not inflammatory, but probably uh, a more like a metastasis or a tumor, a kind of a lesion in the eye.
Right, it's like usually on any mass lesion, you look at the color of the lesion, the margins of the lesion, and associated changes. So the malignancies can also have inflammatory signs, but then like the inflammatory signs are much lesser as compared to an inflammatory granuloma. So overlying cells in a malignancy can be there because of the breakdown of the blood-retinal barrier. And usual malignancies primary to the eye are retinoblastoma, which is usually in children. So the tumor arises from the retina and usually yellowish white in color. In contrast, like the ones which we commonly come across where the patient may present with metamorphopsia would be a choroidal tumor. It could be a choroidal hemangioma or a choroidal melanoma. Hemangioma, like Dr. Vishal showed, it's orangish red in color and usually located in the posterior pole and solitary dome-shaped lesion. Melanoma is brown or black, brown or gray, and can be a dome-shaped or a mushroom-shaped lesion with associated, there can be drusen or orange pigment on the surface. And this will be having an associated subretinal fluid. The subretinal fluid in the melanoma is usually around the base of the tumor rather than on the surface. In contrast to hemangioma, you will find the tumor, the fluid to be on the surface of the lesion. And the ultrasound will show, and usually they are dome-shaped or the shape is dome-shaped or a mushroom-shaped lesion. And ultrasound show these lesions to have a homogeneous intensity, either high reflectivity, low reflectivity, or medium reflectivity, but like a homogeneous lesion in contrast to a coronal granuloma, which may have a different reflectivity in different parts of the lesion. Another thing in the inflammatory lesions, the color of the lesion can be different. So if it's a tubercular granuloma, which is going on to becoming an abscess, some parts can be orange in color, some parts can be white in color, where it's become an abscess, or some part which is scarred can become pigmented in color. So the color of the lesion, the associated inflammatory signs, the exudative detachment, which is often more in a malignant lesion in contrast to a granulomatous lesion, are the signs which we look out for to differentiate an inflammatory pathology for a malignant pathology.
Sure, yeah. Thanks, sir, for the very nice inputs about multiple lesions and to look out for color, size, and also the involvement. Sure. Thanks. Yeah, Dr. Pulkit, you're ready?
Yes, please.
Yeah. Please carry on. Yeah.
Yeah, thank you for inviting me to participate in this webinar. Apologies all around for that bit of a glitch. So we'll be talking about a little about the especially metamorphopsia, but associated visuospatial distortions, which might be associated with cortical or subcortical pathology. Essentially, the things which are retrobulbar. The slides are not moving for some reason.
Probably you can press the space bar and then move on to the next, because sometimes it happens. Yeah.
Yeah, I think that's just the Mac is a bit just
click on the just click on the screen. You should be able to move. Just click on the screen and then
Okay, so till the time yeah, sure. So till the time Dr. Pulkit is sorting out the issues. So one more questions to the panel is how to differentiate a grade 4 ERM or an EFIL versus congenital combined hematoma of retinal and retinal pigment epithelium. So Dr. Vishal, Dr. Guru Prasad, or Dr. Atul, what is your take on that?
The color of combined hematoma of RP and retina and RP is dark. The retina is thickened, and the location, usually it is in the centrocecal area, sometimes all around the disc also. And it can be, in fact, anywhere except at the fovea sometimes. So the difference between ERM, which usually is located at the macula, here it need not be located at the macula. And of course, the other features like younger patients have it, and the lack of progression. I think these are the differentiating features.
What would be your take on operating cases of combined hematomas? So whether any vision is a cutoff, or whether you feel the OCT is a cutoff, or whether you feel that better not to operate and leave them alone?
Me?
Yes, Guru sir, you can take it, sir.
Yeah, I would like to answer this because I've done a few cases. Rather being, more in an enthusiastic mode, not knowing what the outcome will be, just because there was a thick ERM and all that. But then later I realized that it is neither easy nor productive to operate on these cases. In fact, one should not operate on congenital hematomas. Yeah.
So better left alone is the answer. Yes. Anybody else has any other suggestions? Or yeah. So Dr. Vinod.
I had a very interesting case some years back. So this was a case of congenital hematoma. And this patient was diagnosed, young boy, I guess around 10 years of age. He had been diagnosed as ERM and was advised epiretinal membrane removal. So because the parents were a little anxious, they came for second opinion. And at that time, I diagnosed that patient as a combined hematoma of retina and retinal pigment epithelium. And we advised the patient that they should not undergo the surgery. And that is what they actually followed. And a year later, the patient came, and this patient had a spontaneous separation of the epiretinal component. We know that there are three components in a combined hematoma: retinal, the epiretinal, and the RP component. And this patient actually had improvement in vision, and the retinal contour became normal. This case we published in Ophthalmology. And subsequent to that, based on that particular experience, I thought maybe patient who had prominent epiretinal component would be the patients who would benefit from. So with that experience in mind, I did operate close to 6 or 7 patients with the combined hematoma. But of course, not all of them improved, but I would say 50% of them do improve by 1 or 2 lines. But of course, the improvement is not as great as epiretinal membranes. So that is one. Second is one big difference between epiretinal membranes and combined hematoma is the age. So usually, while typical epiretinal membranes without any secondary pathologies we see in older age, combined hematomas we come across in younger age group. And third thing, over the years, since I described omega sign, I have come to see is that many of the secondary ERMs, they actually look like combined hematomas, especially on OCT. So if you see your secondary ERMs, many of them would show morphology, something like omega sign on OCT. So that is something I wanted to comment on.
Sure. Yeah. Thanks. So there was one more important point which Dr. Amandeep had pointed out was regarding counseling the patients with metamorphopsia due to non-exudative subfoveal PED. So whether any of the panelists or Dr. Amandeep would want to add some points to it. So seeing cases like this where there is only a PED and no fluid, but yes, these are not sure whether they are precursors of CSR, but sometimes we have very large PEDs in the subfoveal area, which are just incidental findings. So how would the panelist or would want to discuss this with the patient regarding what can be done or what should be observed and how frequently they should be seen in the clinic?
I only asked because I'm not clear about it. That I want to have an expert.
No, so the question is open to all the panelists.
Sometimes you do a Octa or a FFA in these patients. You see a NVM also, but again, it's non-exudative. So I want to hear what is the opinion from others. Yeah.
So the Guru Prasad sir, the Mahesh sir, Manvi madam.
Since all the anti-VEGFs, brolucizumab is one anti-VEGF which probably has an effect on the PED as well. It has, it subsides IRF, SRF, and in most of the patients, the PED also comes down. And if the PED is really bothersome to the patient in terms of causing distortion of the macula and causing distorted vision, metamorphopsia, I think giving brolucizumab, I've not done it, but I think we can give brolucizumab and see if it has any beneficial effect.
Any more take on
So
that?
Yeah, so we had one interesting case. This is, of course, not a young patient. It is a middle-aged lady who had this large serous PD in one eye. Over years of follow-up, she spontaneously, the PD grew in size, spontaneously developed ribs, and then her vision dropped down to something like 6/60. A few months later, about half a year down the line, she started developing a large PED, serous PED in the other eye also. And on any form of imaging, we could not pick up any neovascular membrane or anything. Not very sure what to do. I gave a trial on eplerenone. She had it for more than 6 to 8 months with absolutely no change in the PED. She had good vision, 6/12, but there were concerns that it's going to follow the same natural course as the other eye did. So finally, the patient went on to receive Pegenax, brolucizumab, And she received 2 injections, and to my surprise, delight, and utter relief, the PED flattened with preservation of vision and without a rip. Now, having said that, I cannot say that this is some kind of an ideal treatment, but this seems to be happening with brolucizumab, as Dr. Guru Prasad just pointed out.
Yeah. So any more discussion on it? Dr. Pulkit, you are ready?
Yes, I'm ready.
Okay. Sure. So shall we continue with the presentation if the panelist is fine with that?
Yes, please.
Yeah. Oh, sure.
Right. Thank you. So let's start off with visuospatial distortions in retrobulbar pathology. We've all discussed, my esteemed panelists and speakers have already told. So metamorphopsia is basically a visuosensory deficit syndrome, which is associated with perceived visual illusion of spatial distortion. So there's a visual component, a sensory component, and along with that, how we are perceiving our space, how it is actually present, how we are perceiving it, and any contradiction or rivalry between that causes metamorphopsia. That's the Amsler's grid, obviously, which everyone uses. And there are some innovations in the field as well. So cerebral metamorphopsia, basically caused by retrobulbar pathology, cortical or subcortical or other neurological illnesses, is relatively rare compared to retinal or essentially ocular conditions. But one thing which is seen persistent with cortical metamorphopsia is that it is chronic, almost always present for more than 12 weeks and generally permanent. Even if it reduces, it does not resolve completely, or the visual parameters never return to the baseline. And associated phenomena are extremely important, especially with the history part, because sometimes we miss out on them, and sometimes the patient does not perceive them as much because there are other pressing concerns like profound loss of vision or hemianopias. So palinopsia and polyopia are the most commonly associated phenomena with metamorphopsia, and the terms are used interchangeably, but essentially these are two different conditions. Palinopsia, in a few words, is the after image phenomena. So there's one object which might have one image or multiple images which we perceive even after the object has moved away or we've closed our eyes, most commonly seen with drug abuse or lesions in parieto-occipital lobe, but also with other neurological conditions. And polyopia is when there are multiple objects in our field of vision, and when we move away from them, these multiple images of multiple objects. So very closely related phenomena with metamorphopsia or distortion of images, along with simple complex visual hallucinations. Charles Bonnet syndrome comes to mind, which is more commonly associated with organic loss of vision after lesions in the retina. But there might be formed and unformed hallucinations as well. Formed, as we know, with temporal lobe lesions, and unformed more commonly associated with occipital lobe. Then color vision abnormalities, dyschromatopsia, red-green are more common, or chloropsia, or alteration of perception of how we are perceiving the image might appear distant. The object might appear farther away, like this perception we have with a convex mirror on the side view mirror of our car. Lilliputianism, where the object appears smaller than it actually is, also called as micropsia. Slightly different, but if we want to simulate it, we can use a minus lens. My myopic colleagues would know when a moderate to high powered minus lens is put, there's a slight minification of image. Then there might be initially during any neurological disorders, there might be transient homonymous defects. Later, they might get converted to permanent, or transient prosopagnosia, which is inability to distinguish faces. There are other things like alexiagraphia as well, but this is the most prominent and associated with occipitotemporal lesions, which is occipital lobe is generally the common site for such lesions, or even disorientation in time and place. There have been cases with Alzheimer's or dementia where also it becomes difficult to actually assess how much or what degree of metamorphopsia the patient has. And artificial intelligence has started entering that arena with the DOVA boxes, which we'll discuss in a minute. So psychophysics is a study of relationship, as we were discussing, between how the physical dimension is and how the psychological dimension is perceiving it. And any rivalry between the two gives rise to metamorphopsia, much more commonly seen with ocular or bulbar disorders, but sometimes also with retrobulbar. And quickly, if we want to find out why this is happening, so almost always in our visual field, there are objects which are sometimes covered or we can't see them properly, and our mind fills in the remaining image. But what happens in case of neurological lesions is that either there has been a reorganization of the retinotopic map inside the cortex, or there has been some epileptogenic discharge, which is causing this filling in of the image to be abnormal. So this abnormal filling in causes distortion of the image, which might give rise to metamorphopsia. So there are 2 or 3 different theories. One is about reorganization, the other is other causes. And basically, a literature review shows us that there are few conditions, neurological conditions, which might present or which might be associated with metamorphopsia. And most prominent of those are cortical or subcortical lesions involving the lobes or thalamus, hippocampus, amygdala, these kinds of things. So the trauma or pathology of occipital lobe or radiation is most commonly associated with metamorphopsia. To a lesser extent, parietal, temporal lobes, and brainstem as well. And the right side, for some unknown reasons, the right side non-frontal lobes or regions are more commonly involved, leading to these symptoms more prominent on the left side. Also, there might be involvement of visual pathways and epileptogenic discharges. And the hypothesis which was applicable here was that because of actual damage, physical damage, and change in anatomy, there is a reorganization of the map inside the cortex, which is causing this. Also, there are other lesser common lesions in splenial, retrosplenial lesions, or cingulate gyrus or occipital horn. But basically, that means that there is either a tumor, there's trauma, or there is damage, which is changing the actual structure or anatomy. Demyelination is another important thing because it is seen more commonly in practice, especially in the West. And as we all know, demyelination is basically the insulating sheath has been stripped off or it is not forming properly. And more commonly, demyelination involving the visual association area in the temporoccipital regions, that means higher processing areas, the radiations is more commonly associated. Also, 2 of the other factors of discharge, epileptogenic discharge, and deafferation is also commonly seen in demyelination, which is very closely related to epilepsy as well. Then there were some objections to this cortical reorganization theory by a very prominent British neurologist, M. Critchley, who said that no, actually, you cannot always blame structural changes to development of metamorphopsia, because he pointed out that when the lower visual processing regions like V1, the primary visual cortex, or the geniculostriate pathways were damaged, were affected when there were lesions, they did not have any permanent anatomical changes, but still they were associated with metamorphopsia. As well as in epilepsy. Epilepsy is a very good example because in it there is no actual structural damage, but still the patient perceives distortion of the spaces. And if there is an actual structural damage, these symptoms will persist even in the interictal periods between seizures, but they do not. So the possible alternative etiology that was suggested is that maybe there is cerebral artery hypoperfusion, or epileptiform discharges or deafferation, which was again, deafferation, which was again supported by similar changes happening in demyelination as well. Now, the second thing, another thing, or another approval of M. Critchley's alternative hypothesis was drug-induced metamorphopsias, especially the ones which we saw in palinopsia, because in those cases also there is no actual structural damage, but there is alterations between the neurotransmitter and neuroceptor relationship. And palinopsia and distortion of lines were more commonly associated phenomena with drug-induced metamorphopsia. So what do we do when a patient comes up? History is extremely important. Neurological part is something which we frequently miss out or we ignore when a patient comes. So history, that at that time and after an assessment, a repeat history is generally required, where we might ask specific questions to elicit details. Obviously, a visual acuity assessment, and after that, very essential, a pupillary assessment, which sometimes, especially if we are inclined for a retinal evaluation, the nurses might already dilate the patient's pupils and present to us, and we leave the valuable information a pupil offers to us, and we might have to call the patient again, or this thing might be ignored. So even though we are not always thinking of a patient to have a neuroophthalmic problem, it just takes a minute to quickly assess the pupil and then actually go to metamorphopsia charting, which is based on 4 principles. First, we have to map the distortion actually, whether it is geometric or bizarre or erratic. Where it is exactly, is it associated with scotoma? What is its aspect and what is its location? Granted, most of them occur within the central 20 degrees, but there might be peripheral as well, especially if they are retrobulbar, and that requires altered charts, M charts, or the newly available charts, because the exactly help if the patient is exactly able to point out or draw what kind of metamorphopsia it is, and on the basis of its shape, whether it is geometric or abstract, we might be able to have a slight clue as to where the lesion is lying, because generally the lower order visual processing pathways, like especially V1, V2 geniculostriate radiations, such are associated with geometric distortions, while abstract are associated with Brodmann areas 18 and above, 3, 4, 5, which cause abstract distortions. So sometimes patients are very astute and they are able to actually draw very clearly what kind of distortion they are facing. Then, if we are suspecting a neuroophthalmic problem, especially in the initial stages, a very valuable and very frequently neglected test is a stereopsis test, because stereopsis is affected in a very subtle way, and sometimes most of the times the patient doesn't even complain about it. Just a very quick test can be done. The 2 best stereoscopic analysis are Frisbee and TNO. The Frisbee is advantageous because it doesn't even require any Polaroid spectrograph or any red-green glasses. And a quick assessment possible. Moving on to color vision. Even if the patient does not have a frank dyschromatopsia, hemiachromatopsia is something which we have found to be extremely valuable. In the same patient, they might not have a good color perception in half of the field, especially outer half of left side is what we focus on, and they might have a good perception on the other side. So that is a very, very subtle change, but very valuable when we are looking at or we are suspecting a neurological problem. Then 6 to 34% of patients might have involvement of 1 or more extraocular muscles. So a quick extraocular motility test. And if we have a dedicated orthoptics department, that is valuable as well. Visual field assessment, the backbone of possibly neuroophthalmology. Goldman kinetic perimetry surprisingly is very popular and sometimes considered a standard because of its wide 120-degree field perception can be mapped in tertiary care centers like Manchester as well. Otherwise, if we don't have access to that, we can use the Humphrey field 120-degree wide field assessment. I bow to my retina colleagues. They have already explained everything that's to be done for retina, so we'll skip that. And then neuroimaging is what we heavily rely on. CT scan, not so much, but yes, if there's a time constraint and we need an urgent answer, the first line of investigation generally after forming a hypothesis is a CT, but then we prefer MRI scans, MR angiograms, and Doppler of carotid is surprisingly very useful because many of these cases have been associated with TIA, cerebrovascular accidents. Now, the innovations which I was talking about is, as I said, sometimes patient has dementia, might not be able to actively inform us properly as to where the distortion lies. So LCD OLED monitors with AI interface, that is called the MATLAB or the Matrix Laboratory Code. It uses a pupil tracker which can actually map which part the patient is missing or sliding on, which part the patient is not being able to fill in, and calculate a degree of visual angle. That is where the metamorphopsia lies, whether it is geometric or it is bizarre, and if it is central or peripheral, and give us more valuable information. So just to quickly round up, because of the time constraint, the two cases that we saw, unfortunately can't share the imaging or the images associated because of data protection, but we had an 83-year-old Caucasian female who was otherwise fit and fine, presented with what appeared to be distortion on the left side. Objects appeared shrunk. She couldn't read properly. There was no associated visual loss or deterioration of vision or amaurosis, but on further asking, she did have a history of an ischemic stroke about 5 years ago. Ophthalmic assessment and neurological assessment was absolutely fine. No problems otherwise, good color vision perception, good visual acuity for her age, she was pseudophakic. But on the basis of this previous history, when she had a neuroimaging done, along with the older lesions, a new recent infarct was also found. She was her symptoms started 72 hours before she presented to the clinic, and it was found that lateral aspect of the right occipital lobe had an infarct. Her symptoms were attributable to a TIA. So that is a very unusual or uncharacteristic presentation. To be honest, we wouldn't have imaged her, but because of her history and the overwhelming suspicion, we go ahead, and this a very valuable symptom, just a bit of distortion or metamorphopsia, and the patient was actually had a mini stroke for which we were able to intervene, our colleagues, that is. Then a 37-year-old Afro-Caribbean female who presented with very drastic symptoms, profound, sudden, painless loss of vision. The left eye was reduced to perception of light. All the red flags were there. RAPD, diagnosis of left retrobulbar optic neuritis. Supposedly, we are suspecting demyelination. She was given intravenous methylprednisolone. At 6 weeks follow-up, there was a tremendous visual recovery, as is, but she had persistent metamorphopsia on the left field of vision, very characteristic, and associated palinopsia as well. Now, that time when we asked, she did confess that before the loss of vision presented, she did have slight distortion, this similar distortion, which she chose to ignore, like most of us do, just dryness of the eyes or something. But even when her vision recovered, it did persist. So it was there before, it lasted even after the vision had recovered. Later, she was actually found to be a neuromyelitis optica spectrum disorder patient, and so the care was taken over by the neurology department. But MRI scan did show demyelination, hyperintense and hypointense signals, mainly in the occipital region, little bit of the contralateral frontal region, and pericallosal, that means the lower processing areas as well. Now, even though because the vision had recovered, there's no actual intervention, but the patient's visual perception symptoms improved a bit, but never returned to baseline. She did have had this persistent distortion which state. So basically, after we rule out all the obvious things, the retinal and ocular pathologies, it's worthwhile to go a little back, think up till the visual cortex, and go ahead, investigate, might be able to find something which is causing the symptoms.
Sure. Yeah. Thanks, Dr. Pulkit. And it was very intriguing kind of a presentation. And just to inform that Dr. Pulkit is also a writer, which he has won the American Writing Award for his book, I Am Wrong, You Are Right, and I'm Sorry. Thanks.
Thank you.
Yeah, so it was way beyond my understanding as I'm a VR specialist.
No,
the function ends at retina and starts at choroid probably, and beyond sclera we give it to uvea specialist. But beyond that, it is it's just very difficult to comprehend. But yeah, thanks, Dr. Pulkit. So
no, you're very kind, sir. You're very kind and.
Thanks, Pulkit. Okay, so any questions or discussions from the panelist or Dr. Thiru, my moderator or partner in crime?
I mean, he really presented very lucidly, but then I was neurophthalm was one subject which I was flummoxed away. The moment I used to see the eyes go on either side, I was like, yeah, ye nahi hoga mere se. So I think probably anybody else has question from AV team, then yeah, that's
So,
fine. I think Dr. Raman had a point.
I think we must give the credit to the writer. He has done a great job. This is what, before I heard this talk, even heard this topic, that I never knew there is something called the cerebral part of the metamorphopsia. I always thought of migraine and that's all, I was always thinking. But yes, if we have ruled out, the retinal causes, of metamorphopsia, and then where to go. I think these are the very nicely illustrated by him, that these are the cerebral causes we should look for, and they're very important actually. So very nice presentation. I really liked it actually. Yeah.
Thank you, sir. You're very kind.
Dr. Pulkit, one question, Dr. Pulkit, what is reversal of vision or metamorphopsia? Is there anything where the metamorphopsia reverses also?
Sir, actually,
cerebral metamorphopsias, yeah.
No, as I said, most of the metamorphopsias, what we have seen, first we see them to a very lesser extent, because there are other more pressing concerns. The patient is losing vision or half of the field. So that is not exact. That is neither the patient's priority, and to be honest, it should be ours, but it isn't. But a few astute patients who do perceive this, these retrobulbar causes for metamorphopsia, they are absolutely chronic. During the acute phase of demyelination or even other inflammatory causes, they are very prominent. And once the acute phase passes or the patient goes on interferon or autoimmune therapy, they do reduce significantly. But we've never found the patient say that they are absolutely happy now, that it has completely cleared up. There always remains a little bit of distortion, which they always perceive. It never goes away. So most of them are, almost all of them are chronic, most are permanent as well.
Sure. Thank you. Yeah. So any more discussions or points to add? Okay. So just to summarize, so we started with so where he showed us what are the pointers to look at, whether it is anterior segment or the posterior segment associated. So most important pointers were whether those are symmetric and non-symmetric and involving the central visual field or the peripheral, because optical and other associated metamorphopsias would be more peripheral and less central, as we were discussing about pincushion effect or the other effects. And then the next presentation was Dr. Vinod Agarwal, where the sir suggested that vitreoretinal interfaces, most important is the history, yes, that can be presented as metamorphopsia, but the OCT or the imaging is what is the key. Imaging involves multimodal imaging, which is involve your clinical examination, a fundus photograph, and if possible, a structural OCT itself to identify the issues at the vitreoretinal interface, and yes, manage accordingly depending upon following it up with either a VI specialist or a referring over there. And the next presentation, which was again a very exhaustive presentation, was by Dr. Kalpita, which involved the vascular part of the metamorphopsia, which involves vascular, both retinal and choroidal. As you could see, it was an endless list where Dr. Kalpita was also probably tired till the end of the whole presentation because there are so many things to cover out of it. But yes, if you see something abnormal, some kind of a swelling at the posterior pole, or probably having an hard exudate, or probably having an hemorrhage at that particular area, again, those are the pointers that probably try to get an imaging. Again, imaging to discuss if you have a structural OCT, as discussed by Dr. Ramandeep sir, again, that there has to be a very tight or a compact, dense OCT performed at the site of suspicion so that we are able to identify what kind of lesion it is and then intervene accordingly. The next presentation was something which is associated with inflammation or uveitis, where Dr. Partho had shown us different various propositions of metamorphopsia associated with inflammation and uveitis. Most important being SO, where one eye is already lost for certain particular reason that can have a presentation in the other eye having a neurosensory detachment, or there can be a VKH kind of a presentation where there can be systemic signs and there can be ocular signs like redness, pain, and associated signs which can also be present in cases of inflammation. So adjuncts were very important to ask the history adjuncts, and again, multimodal imaging like angiography was helpful in these cases where we can see either leakage or kind of a different kind of a presentations for SO, and you can rule out non-inflammatory components like a CSC, like one of the cases which was shown that one eye was damaged because of the trauma where it was PL negative, but the other eye had just CSC rather than an SO. The next presentation was very ominous kind of a presentation where it was secondary to multiple neoplastic causes and miscellaneous causes. Very important discussion which happened on a very common pathology like PFT, how that can be differentiated from a tamoxifen kind of a toxicity. And yes, there were multiple tumors which were discussed, which are retinal, choroidal, and as Dr. Mahesh suggested, very important is to look for associated signs and systemic history. In certain cases, there would be a past history of some kind of a like a breast cancer surgery, or probably the patients can itself present as a first presentation to an ophthalmologist as either a unilateral or a unifocal kind of a lesion, or bilateral or multifocal kind of a lesion of metastasis, and there can be other benign lesions also, like the important thing which we were discussing regarding what would be the indications for a combined hematoma. Yes, sometimes that can be mistaken with a very advanced grade 4 kind of an ERM or an IFIL. The last presentation was by Dr. Pulkit, yeah, which was way beyond my clear understanding. But yes, Dr. Pulkit has tried to present as lucidly as possible, where there can be associations not only from ocular, but also retroocular, or probably involving the neurological causes also. So some takes on that is to look in for other adjuvants like either having squint or systemic disorders or a past history. And yes, also multimodal imaging, not only intraocular but extraocular, like utilizing an MRI to look for any demyelinating kind of a lesions. And as Dr. Ramandeep was suggesting, that migraines can have metamorphopsias or polyopsias, but those sometimes resolve. So with this, we come to an end of a very interesting webinar, which was planned by Dr. Santosh and team, that metamorphopsia, what to think and how to triage and how to manage. So we have tried to cover most of it. There would be some lacunas. Yes, we have overshooted the time by probably 43 minutes. But yes, if anybody wants to add anything to it, Dr. Santosh, if you are online. Okay. Dr. Santosh. So Kripal sir. Dr. Tirumalesh, do you want to add something? I'm not sure AV team is
No, I think it's been a quite exhaustive session, and I think we should thank all our speakers and also the chairpersons and the expert panel who sacrificed a Saturday, and they were all there with us and discussed a very important topic. And it's pretty late. I think we should call it a day.
Sure.
Thank you, everyone. Thank you, sir.
Thank you.
Thank you.
everyone.